Good evening, ladies and gentlemen. It's a welcome Friday, and it is day 5th. Welcome to an update in lymphoma. As all of us know, it includes best of 16th ICML, International Conference on Malignant Lymphoma. First 4 days has been very exciting. It has presence of many countries, more than 1200 plus registration. And that is possible because of our teachers of teachers, Professor Dr. M.B. Agarwal sir, who has inspired and who have brought in some of the best international speakers in the last, we were just counting, and it is already 205 webinars post-COVID. So thank you for enriching us, sir. And may I request you to take it on from here.
Thank you, Dr. Manoj. So good evening, friends. As was mentioned by Dr. Manoj, today is the 5th day of the update in lymphoma, which includes the best of 16th International Conference on Malignant Lymphoma held in Lugano a couple of months ago. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS, managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from INTAS, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our international guest speakers, and the three of them this evening, our chief guest, additional Professor Dr. Prashant Ganeshan, our discussants who are eminent hematologists or medical oncologists, and you participants, the most important, for sparing your evening and joining from almost 10 plus countries all over the world. Day 5, Friday, 17th September. Discussants today include Dr. Chirag Shah, Director, Hematology and Medical Oncology at Apollo Hospitals International, Ahmedabad. Dr. Ayaz Ahmed, Senior Consultant, Hemato-Oncology and Transplant Team, Department of Hematology at the prestigious Rajiv Gandhi Cancer Institute, Rohini, New Delhi. Dr. Sanjeev, Associate Professor, Department of Hematology, SGPGI, Lucknow. Dr. Lalit Mohan Sharma, Senior Consultant Medical Oncologist, Sri Ram Cancer Center, Mahatma Gandhi Medical College and Hospital, Jaipur. Dr. Chepsi Philip, Senior Consultant Program Director, Regional Advanced Center for Transplantation, Hematolymphoid Oncology and Marrow Diseases, Believers Church Medical College Hospital, Tiruvalla, Kerala. Dr. Sanket Shah, Consultant Hemato-Oncologist, Stem Cell Transplant Physician, HOC Vedanta, Ahmedabad. Dr. Smita Kayal, Associate Professor, Department of Medical Oncology, Regional Cancer Center, Jawaharlal Institute of Postgraduate Medical Education Research, that is JIPMER, Puducherry. Dr. Varun Bafna, Hematologist, Hemato-Oncologist and Transplanter at Dr. Bafna's Star Clinic and Hospital at Kolhapur. Dr. Asif Iqbal, Assistant Professor, DMG, Adult Hematolymphoid, Department of Medical Oncology, Dr. Bhubaneswar Barua Cancer Institute, Guwahati. And Dr. Kripa Bajaj, Consultant Medical Oncologist at Indo-American Cancer Hospital Research Institute, Hyderabad. It's my proud privilege to introduce my friend and the chief guest of the day who is going to inaugurate our webinar. We are privileged today by the kind presence of Dr. Prashant Ganeshan from Puducherry. He doesn't require any introduction, but I must complete the formalities. He's working as additional professor at JIPMER, Puducherry since 2018. After finishing UG and PG from JIPMER, he completed DM Medical Oncology Fellowship training at AIIMS, New Delhi, where he was the recipient of the Best Student Award. With a keen interest in teaching, he has pursued an academic career. After joining Cancer Institute at Diyar, Chennai in 2010, he was actively involved in the training of DM students and helped in the expansion and evolution of the training program at that center. He has received training in bone marrow transplantation and phase 1 clinical trials at the University of Texas MD Anderson Cancer Center in 2012. A special interest in hematological malignancies, ovarian cancer, and supportive care in cancer. He has been PI of several oncology clinical trials and has served as members in various research and ethical committees. He's the lead investigator of Network of Oncology Clinical Trials India, which is a multi-center effort to conduct collaborative clinical trials and is supported by a grant from the National Biopharma Mission. I request Dr. Prashant Ganeshan to inaugurate today's webinar and give us some words of wisdom. Over to Dr. Prashant.
Thank you very much, Dr. Agarwal sir, for a very, very kind introduction. It's a great pleasure always to be part of any function which is organized by sir, because it always promises to be an academic feast, always well organized, and he gets the best speakers. Thank you very much for including me as part of this program. And the Lymphoma updates always excites us. And Lugano meeting is something which we always wish to attend, because it's where the cutting edge research is presented in the field of lymphomas. And a very important subject for so we are in a very revolutionary stage in the field of oncology in general, and of course in hematological cancers. There is something new happening every day. Great changes in the understanding of the biology, the therapy, one that's guiding the other, and this is an exciting phase where we are trying to move away from conventional cytotoxic chemotherapies to chemo-free avenues. And every day there's a new molecule which seems to take us closer to that goal, make the journey of the patients easier, and as well as increasing the cure rates and the control of the disease. Exciting to know and understand these changes. One of the most exciting things about being in the field of oncology. You just see the, if you just look at the number of articles published in any field in the New England Journal of Medicine, you will see that the maximum number of articles are in the field of oncology. So this shows that whoever is in this field, we want to be here because this is the most exciting field of medicine, as far as I'm concerned. And every day is it's a new opportunity to learn, which is what really kindles that passion to be in this field. For young oncologists and hematologists, particularly lymphomas, very important area of understanding the biology of cancers. And this is where we actually, because the solid malignancies are often taken care by the surgeons and radiation oncologists. They do all the cutting and removing and giving adjuvant therapies. We really don't see the tumors. Lymphomas is where we can actually see the tumor, and we can see the tumor melting with our drugs, which makes it very exciting actually. So I still remember, like during my MD time, we had a lymphoma patient badly affected by maggots that completely ulcerated. It took some time for us to clean it up, and at that time I was really not thinking that this would go anywhere. The patient was very sick. Eventually, after many days of cleaning and the debridement and everything, and finally we gave him CHOP, which was what was available at that time for lymphomas. I think for every lymphoma we gave CHOP. It was quite dramatic. The patient in a few days that the wound had completely healed up and he looked fantastic. And I still remember the patient used to come back and he looked very well. I mean, that was one of the things which took me to the subject of oncology. It was very dramatic, and the field of hematology oncology continues to fascinate me to this day. What you can potentially achieve with our fantastic drugs. Things have only improved in the last decade or so. I have been in this field. I hope all of you find your inspiration from your everyday work and training, and it helps you to keep the passion for caring for the patient, which is very important, and the passion to learn your subject, keep updating yourself, and also the passion to research and understand. So I think today is one occasion where you can kindle your passions and understand more about lymphomas, because we have very exciting speakers lined up. So I wish everybody the best and enjoy this fantastic academic feast. So thank you once more for having me.
Thank you, Prashant. We are extremely grateful to you for sparing your time and inaugurating today's webinar and giving those words of wisdom. Dr. Don Derricks is our first speaker. He has already logged in. It's my pleasure to introduce him. Dr. Don Derricks, we are grateful to you for having accepted the invitation and being with us. He's Professor, Department of Hematology at University Hospitals Leuven in Belgium. And he's going to speak to us on post-transplant lymphoproliferative disorders. Over to Dr. Dandaris.
Thank you very much. So first, I want to thank you for the very kind invitation. It's a real pleasure and an honor to be here. Unfortunately, not in real life, but I really hope we will meet in real life once. It's a pleasure to talk about my main topic of interest in research and clinic, post-transplant lymphoma. And I will first try to share my screen. Can you see my screen?
Yes, sir.
Yeah, okay. So thank you very much again. So post-transplant lymphoproliferative disorders will be the topic of my talk. These are my disclosures. So I think you are all aware that transplantation is a very complex phenomenon, and in the first years of transplantation, actually, the long-term survival of patients was limited due to acute rejection, due to infection. But because of improved graft survival, because of increased recipient age, the use of more potent immune suppression, actually the focus of complications has shifted from early complications to more long-term complications, including cardiovascular complications and, of course, malignancies. And as you can see on this figure, the risk of having a malignancy is increasing with 20% after 10 years of chronic immune suppression. And this can be all kinds of malignancies. And of course, one of these, as already told, is PTLD or post-transplant lymphoproliferative disorders. Actually, it was already described in 1969 by Israel Penn, who described a series of 4 patients who developed lymphoma following immunosuppression with cyclosporine. When we look at the cumulative incidence, we can say that it's about 2 to 2.5% when looking at all kinds of transplantations. The problem with those information is that in contrast to, for example, Hodgkin lymphoma or CLL, we don't have large prospective studies, and most information is based on 2 kinds of sources. On one hand, large transplant registries, and on the other hand, single or multi-center studies, retrospective ones. And as you can see in this table, both are associated with advantages and disadvantages. And here you see the most important single center studies. And as you can see in the numbers, the typical numbers are about 50 to 150. And these are data from different transplant registries. And in this picture, you see the standardized incidence ratios. So the standardized incidence ratio is the ratio between the observed cases and the expected cases in the normal population. And for non-Hodgkin lymphoma, you can see that this is about 10. So there are 10 times more cases with lymphoma, non-Hodgkin lymphoma following transplantation compared to the normal population. And actually, we have a bimodal curve. We see an early spike in incidence the first year, which is followed by what we can call not a spike, but a wave. It's a kind of plateau. And as the survival of patient is increasing, we now know that the wave is becoming longer and longer. And now we often see patients who have been transplanted 20 to 25 years ago developing a lymphoma. This is a little bit different if you look at solid organ transplantation compared to hematopoietic stem cell transplantation. Those bimodal curve is clear for the solid organ. So you have 30 to 35% in the early spike and the remainder are in the late wave. In hematopoietic stem cell transplantation, almost all cases are seen in the first year, and I will come back to this later. We rarely see late PTLDs in the hematopoietic stem cell recipients. What are the risk factors? There are a lot of risk factors, and the first is the organ type. So here you see again data from a registry, and you can see that kidney transplantation have the lowest risk to develop a PTLD, followed by liver, lung and heart, and finally multi-organ transplantation. And these are our own data. So we have about 200 PTLD cases over the last 25 years. And you can see that the incidence is indeed the lowest in the kidney, followed by liver, lung, heart. And of course, we don't have that much multi-organ transplantation. So we need really registries to see that the risk is really increased in those kind of transplant patients. For allogeneic transplantation, it's of course different. There, the use of selective T-cell depletion or ATG is considered the strongest risk factor. So you can say the more mismatch your donor, the highest the risk to develop a PTLD. This is an interesting study from the Nordic Liver Transplant Registry showing that, and this is for all kind of malignancies. So you can see in the x-axis all kind of cancers. And there you see in the y-axis the standardized incidence ratio. And you can see that during the years, the incidence ratios have decreased for all types of cancer. And this is due to, of course, improved patient management, increased focus on long-term complication, but also important cancer surveillance protocols, so UV protection, no smoking, regular dermatological controls. And another major impact factor in liver transplantation is that it's the only kind of transplantation in which immune suppressive minimization protocols are made. So it means that the further you go from the transplantation, the lower the immune suppression is given, because the liver is a kind of tolerogenic potential across rejection. So you really can try to minimize and even stop liver transplantation, liver immune suppression in transplantation of liver donors. And there you can see that also here you see the non-Hodgkin lymphoma, that the incidence of non-Hodgkin lymphoma really has decreased. That's also what we see in our own population. During the last 5 years, we only had 2 PTLDs following liver transplantation anymore. The second and probably the most important signal factor is the EBV status at the time of transplantation. So if your patient is EBV seronegative at the transplantation, especially if you receive a transplant from an EBV positive donor, your risk is increased to develop PTLD with 10 to 75-fold times. And this probably explains why PTLD actually is more common in the pediatric transplant population compared to the adult transplantation. And the risk is, of course, the highest in the first year, but actually EBV seronegativity at the time of transplantation remains a risk factor even years after transplantation to develop an EBV positive lymphoma. And the third risk factor is, of course, the immune suppression itself. And I will split up this slide in 2 parts. The first part is the one above the arrow. So this is the solid organ transplantation. And you all know that patients often receive induction regimens followed by combination oral maintenance therapy with different doses, with different alterations in their therapy because of rejection episodes. So I think it's clear on this figure that it's very difficult to determine the real contribution of each immunosuppressive medication separately. And there have been some attempts, so we know there is an increased risk with ATG, although this actually is dose dependent with some other immune suppressive therapy, whereas, for example, mycophenolate mofetil and the anti-CD25 monoclonal antibodies seem to be more protective against the PTLD development. And so actually we can say that the first spike actually is a consequence of the induction regimen and is mainly caused by, or is almost fully caused by EBV, whereas the late wave actually is more due to the cumulative immune suppressive intensity and can be EBV positive or EBV negative. In hematopoietic stem cell transplantation, it's of course different. You have the conditioning regimen, you have the maintenance therapy, to prevent or to treat acute GVHD, but after 6 to 12 months, immune suppression is stopped, and the only patients who receive ongoing immune suppression will be the ones who have severe chronic graft versus host disease. And so actually you only have the first spike, which is mainly due to the conditioning regimen and is EBV driven. And you don't worry, there's nothing wrong with your eyes. It's just an illustration to show that the late wave is almost not existing in hematopoietic stem cell transplantation. And here again, you see some population, some transplant registries showing that the risk to develop a Hodgkin lymphoma, the standardized incidence ratio is about 3 to 4. And for Hodgkin lymphoma, as I already told, it's 9 to 10, which is actually a bit similar to the first part of the table are the HIV patients who also have an increased risk to develop lymphoma, especially when they are not treated with antiviral therapy. And this is also an interesting study from the Australian and the New Zealand kidney transplant registry, showing that, so you see three parts. The first part is the time before patients were on dialysis, before they were on renal replacement therapy. So they have their underlying kidney disease, but they are not dependent from renal replacement. The second part is during dialysis, and the third part is after transplantation. And when you look at lymphomas, for example, it's similar with a lot of other cancers, but to lymphomas, you can see that the risk is only increased after transplantation. So the underlying disease and the dialysis in se are not associated with an increased risk to develop malignancies. The only exception is, of course, when you have an underlying disease which necessitates immune suppression, there is, of course, an increased risk for immune suppression related lymphomas. And then there are not a lot of other risk factors, but in contrast to the first three, they are less well validated, and I won't go into detail because they are, whether they are only described once or not validated, but I'm sure there are several other risk factors explaining the development of PTLD. So when we look at pathogenesis, it is clear that we have EBV positive and EBV negative cases. So the green numbers are our own data. So about the half or 1/3 of the patients are EBV positive. The other part is EBV negative. For EBV positive, it's clear that the immune suppressive medication leads to a deficient EBV specific cellular immune response. For EBV negative, the pathogenesis is less clear. And when we look at EBV positive cases, they can be early, so the first year, but also a lot of late PTLDs are EBV driven. For EBV negative, almost all cases are late PTLD, and EBV negative cases are rarely seen in the first year following transplantation. So I think you all are aware of the EBV as the kissing disease. So when you infect someone, your epithelium will be infected, but EBV will also infect naive B cells. And these naive B cells will enter the germinal center and will actually do the same as B cells which come in contact with an antigen. So the EBV expresses during its passage through the germinal center will express a lot of latent antigens, and those latent antigens will allow the B cell to develop throughout the germinal B center, and finally will lead to lifelong persistence of the EBV in memory B cells. And at that time, all latent antigens will be shut down, and so this cell will be invisible for the immune system. And the latent antigens that will be expressed, so there are different programs, they are called the latency types or the latency programs. And so you have the latency type 3 expressing a lot of latent antigens, 2, 1, and 0. And very important, from time to time, memory B cells will actually be activated and will express lytic antigens, making a patient contagious again. So EBV is a very clever virus, it leads to persistence in the host by means of the memory B cells, but also by expressing from time to time lytic antigens, there is a persistence in the population. So, I don't know if the question, yeah, sorry, I will ask the questions, I will do the answers afterwards. Sorry, I will remove them. Yeah. So why is this important? Because the immune system will actually normally strictly regulate the EBV transformation. But in patients with PTLD, they have a decrease in T cell response, and so the EBV can lead to malignant transformation. And actually, we have another example. This is in Hodgkin. About 30 to 40% of Hodgkins are EBV associated, and in Hodgkin there are crippled B cell receptors, and normally this will lead to apoptosis, but EBV can rescue those B cell receptor crippled cells, and this will finally lead to the Hodgkin-Reed-Sternberg cells. So EBV has a real capacity to proliferate and to cause malignant transformation. And this is due to those different latent antigens, which all have, I won't go into detail, but they all have different oncogenic potential to lead to malignant transformation. And that's the difference with other herpes viruses, which can also be lifelong in the body of a patient, but they don't have oncogenic potential in se. Another way to characterize PTLD is the difference between donor-derived and recipient-derived. So donor-derived, the typical example are hematopoietic stem cell transplantation. So almost all cases are donor-derived. This means that the infected B lymphocytes are transmitted with the graft into the patient. Then there is the recipient-derived, and that's what we mostly see in solid organ transplantation, about 85% of the patient, in which actually a primary EBV infection or an EBV reactivation in rarer cases will lead to the development of PTLD. But it's the donor, it's a recipient B cells which will cause the PTLD and not the donor B cells. Important is that also 50% of the solid organ transplantations are also donor-derived, and this is mainly due to the case in transplant recipients which have transplants with large blocks, like intestinal transplantation, like lungs, which can contain a lot of donor lymphocytes. From a clinical point of view, it's important to know that in contrast to classical diffuse large B-cell lymphoma, for example, there is a high incidence of extranodal involvement. And when you look at different series, the gastrointestinal tract is the organ system which is most commonly involved, followed by pulmonary system, bone marrow, the allograft, especially in case of donor-derived PTLD, and the central nervous systems. We use PET-CT as a staging, although it's never really compared to CT, but PET-CT has a real high accuracy in the detection of PTLD. So when you ask what is PTLD to patient or to trainees, actually it's intriguing how confusing this is. So the name itself, post, so it develops after transplantation. It can be early, it can be late, that's okay. It's after transplant, an allo transplantation, so allogeneic or solid organ transplantation. It's a lymphoproliferative disorder, so there is an excessive production of lymphocytes. But actually this definition does nothing say, do we have to include all lymphomas in this entity? Is it a cancer or is it just a disorder? And is EBV necessary? It doesn't, the definition doesn't tell it. And the WHO classification of 2016 actually categorized PTLD in the larger group of immunodeficiency associated lymphomas, together with primary immune deficiencies, HIV, and other medication-induced lymphomas. And actually, you have 4 large subtypes. You have the non-destructive PTLD, you have polymorphic PTLD, monomorphic PTLD, and the classic Hodgkin lymphoma PTLD. And the first 2 can be considered precursors. They are not really cancer, they are precursors, and they are almost always EBV driven. And then you have the true lymphomas, which can be EBV positive if EBV negative. Importantly, about 90% of the monomorphic PTLDs are CD20 positive diffuse large B-cell lymphoma. The indolent or the small cell lymphomas are excluded in the WHO classification, except for rare cases of EBV-driven mild lymphomas. And this is just as a reminder, the definition of the 3 subtypes or the 4 subtypes according to the WHO classification. An important difficulty is the first category, the non-destructive PTLD, which is mostly EBV, but even if it's not EBV, the WHO classification categorize it as a PTLD. And I will just show the difficulty in this figure. So you can have non-destructive, which are called reactive lesions. These are, for example, CMV. So you have B cells, you have an accumulation of B cells infected with CMV, but they will not lead to cancer. They will lead to organ dysfunction. They can lead to death, but they are not cancer. So you have to treat the CMV, but you don't need to reduce immune suppression if treatment of CMV with antiviral agents is enough. If you have EBV, we know that EBV can lead to malignant transformation, which are the dark cells. So if you don't treat them with, for example, reduction of immune suppression, this will lead to post-transplant lymphomas. So actually, the WHO classification considers both as PTLD if you have a lymph node biopsy. But from a clinical point of view, it's very, very important to not cause chaos in the head of the patients and of the transplant physicians, because this is not what we call in clinical practice a PTLD. But according to the WHO classification, if you have a reactive lesion in a transplant patient, you should call it a non-destructive PTLD. And this is an example of how we try to improve the WHO classification. As you all know from the first talk of Professor Sverdlov on Monday, we are currently working on a new classification, and I hope this will be much more clear than the current one. A very important question is, are there differences in EBV positive and EBV negative lymphomas? As you can see, the number of EBV negative cases is increasing. There are a lot of hypotheses why this is the case, but actually the most important question is, are EBV negative cases real PTLD, or are they just de novo lymphomas existing in transplant recipients? And there are some arguments pro the fact that they are real PTLD, and the most important is that a subset of EBV negative monomorphic lymphoma respond to reduction of immune suppression alone, which of course is never the case in diffuse large B-cell lymphoma in immune competent patients, for example. On the other hand, when we look at transcriptomic and genomic data, you can see there's a clear distinction between EBV negative and EBV positive cases, and that the EBV negative cases cluster together with the immune competent diffuse large B-cell lymphoma. So when you look at copy number aberrations, EBV positive cases are much less complex compared to EBV negative. And in the EBV positive cases, the most commonly seen copy number aberration was again in 9p24, which is the place where the PD-1 gene is localized. And I won't go into detail on this, but this is a very elegant paper from the French group looking at the tumor microenvironment, and especially at NK cells, which have a different expression of PD-1 ligand and of TIM3, another checkpoint inhibitor, and checkpoint molecule, which is different in early and in late PTLD, and in EBV positive and in EBV negative. And I think we are now looking at the tumor microenvironment more and more, and maybe this can lead to possible NK cell driven therapies or NK cell based therapies, taking of course into account that the microenvironment of transplant patients is a very dynamic thing. The microenvironment of a tumor will not be the same 1 month following allogeneic transplantation compared to 4 months. So it will be very dynamic, and it will be very difficult to prove all those differences. But it's a very interesting topic. So once again, this is our current understanding. So we have the first peak, which is based on EBV. The second peak is based on the cumulative immune suppressive and is caused by genomic aberrations and doesn't need EBV to develop PTLD. So when we look at treatment, there are actually 3 cornerstones. You can restore the T cell function, reduce the tumor, and targeting EBV. So restoring the T cell function, this can be done in 2 ways. The first way is reduction of immune suppression. Unfortunately, we don't actually have uniform guidelines on this. Most centers will agree to stop the antimetabolites, reduce the calcineurin inhibitor dose, and continue or increase the steroids. If possible, you have to wait for a couple of weeks. And then, as you can see here in 2 trials, the overall response rate is really different. In this trial, the overall response rate was 37%. In another American trial, it was 0%. So it can be very heterogeneous, the response rates. On the right part, you see a graph of an actually challenging trial, retrospective, of course, but showing that when you keep on the antimetabolite, so the azathioprine, that actually the risk to have refractory or relapsed PTLD is not increased. So this really challenges our current concept of this kind of reduction of immune suppression. And of course, reduction of immune suppression is organ dependent. So in kidney transplant recipients, you can do it more easily because you have dialysis as a rescue. In heart transplant recipients, if you propose to a heart transplant recipients to stop all immune suppressive, his looks will kill you, because if you stop immune suppression, all immune suppression, there is a substantial risk for sudden death because of acute rejection. And the rejection rate, it's very difficult to see it in the literature, but with a reduction of immune suppression, the series, the percentage range from 50 to 40%. Another way to restore T cell function is adoptive immune therapy. As I already told, PTLD is actually characterized by a latency 3 type. So it means that a lot of latent antigens are expressed, in contrast to other lymphomas, like for example, Hodgkin lymphoma, who have a latency type 2, and Burkitt lymphoma, which only have an EBNA1 expression, which is called latency 1. And this makes that because of those different latent antigens, PTLD actually is a very good example to look at the use of EBV-specific cytotoxic lymphocytes. There has been interest from the 90s on, but actually it's only the last years that the interest really become increased, because it was very labor intensive. It was not available in a lot of countries. It was costly. So it didn't gain much interest until the last years. And actually the first example of adoptive immune therapy was the administration of donor lymphocytes after hematopoietic stem cell transplantation. But as you all know, this is associated with a substantial risk for development of GVHD. You can make EBV-specific cytotoxic lymphocytes from the patient itself, which is of course of no use in hematopoietic stem cell transplantation, as the PTLDs are mostly of donor origin, which can be applied in solid organ transplantation. And the opposite is true for donor-derived EBV cytotoxic lymphocytes, which can be given in hematopoietic stem cell transplantation, but are less effective in solid organ transplantation, given that they are mostly receptor derived. And so the most interest is has become in third-party EBV CTLs, which can be given in both groups. And this is just two tables, one with donor-derived and one with third-party, and the trials here. But I will just show you the results of some studies with third-party trials in treatment, seeing that the response rate in and here the overall survival rate in hematopoietic stem cell transplantation and stem cell and solid organ transplantation is high with those EBV-specific cytotoxic T lymphocytes derived from third-party donors. They are actually based on one hand, the HLA sharing. You don't need a full HLA match, but you need a partially HLA match. And on the other hand, they are based on HLA restriction. And with this approach, actually a lot of there are very promising results in patients who are rituximab refractory. And this is just an example of the ALLELE study, which is now running in different American and European countries with tabelecleucel. It's a product. It's actually our EBV third-party, partially HLA matched EBV-specific cytotoxic lymphocytes, which can be given in hematopoietic stem cell transplantation refractory to rituximab, or in solid organ rituximab to refractory to rituximab or to rituximab and chemotherapy. And an important concept is the fact that there is a possibility to what we call the allele switch. So meaning that if the response is not good on one product, you can receive product from another donor, which can be repeated for 3 times. So, and you can have 3 cycles, and every cycle consists of 3 administrations of EBV-specific cytotoxic lymphocytes. Second cornerstone is reduction of the tumor, which can be done by local therapy, for example, radiotherapy or surgery, and of course with rituximab and or chemotherapy. And here are some older trials with or retrospective analysis with chemotherapy. And as you can see, the 5-year overall survival was poor with chemotherapy alone and was associated with a high PTLD or treatment-related mortality. And in the first years of this century, the interest in rituximab became increased, of course, given the good results in diffuse large B-cell lymphoma and other lymphomas. And some phase 2 trials really showed promising results with a good safety profile. And so this led to the very large trial in Europe and Australia, the PTLD-1 trial. Initially, the PTLD-1 trial was based on the sequential treatment approach, meaning that patients after reduction of immune suppression received 4 cycles of rituximab, and then they were given 4 cycles of CHOP21. However, on an interim analysis, it was seen that patients with a complete response after 4 cycles of rituximab had a very good outcome. So the protocol was amended, and it was based on a risk stratified sequential treatment. So if patients had a complete remission on CT, they were given 4 additional cycles of rituximab every 3 weeks. If not, they received R-CHOP21 every 3 weeks. And these are the results, very promising. The whole group median overall survival 6.6 years, but importantly, 25% of the patients could be saved or could be rescued from chemotherapy. So 25%, 1 of 4, has a complete remission after rituximab only and can proceed with rituximab monotherapy. Importantly, there was no difference between EBV positive and EBV negative cases. And we looked at risk factors predictive for a better overall survival, a low IPI, response to rituximab, as I already told, and the type of transplant, with abdominal transplant recipients having a better prognosis compared to thoracic organ transplant recipients. And here, this just to say that the study was based on CT, but both the German as our group has looked to interim or end of treatment PET. And the most important conclusion is that when you have a negative interim PET or a negative end of treatment PET, prognosis is very, very good. So PET scan really has a good negative predictive value. And just one word, if patients relapse after CHOP, there is a possibility to give high-dose therapy in autologous transplantation. So this is a retrospective registry from the European Bone Marrow Transplant Register, showing that autologous stem cell transplantation after solid organ transplantation is feasible with 3-year overall survival of 61%. However, the non-relapse mortality is rather high and is mainly due to infections in this vulnerable population. This was, of course, for CD20 positive lymphomas, in which rituximab is now considered the standard of care, and in polymorphic and diffuse large B-cell lymphoma. However, as you know, a minority of patients have other subtypes, and here for plasma cell neoplasias and for Hodgkin lymphoma, the only thing I can say is that prognosis has improved by giving the patient the same treatment as you would give in immune-competent patients. There are 3 difficult ones. First, there is the Burkitt lymphoma PTLD. There are conflicting data, and there have been some reports with RIS and rituximab only, but I don't think that's a good solution. Some say RIS plus R-CHOP is good, dose-adjusted epoch, short course epoch, short intensive course. Actually, I don't know the answers. There might be a subset in which R-CHOP is enough. The most important message will be that if you have bone marrow involvement, the prognosis is really poor. And in those cases, I think the more intensive protocols should be encouraged. Another very difficult one is the primary central nervous system PTLD, in which you can also give RIS plus rituximab. So especially in polymorphic PTLD, we have seen some complete remissions. Whole brain radiotherapy, high-dose methotrexate can be given, but probably the most promising is EBV cytotoxic lymphocytes, as it has been shown that the malignant cells in the cerebrospinal fluid, they still express the different latent antigens, so they can be given EBV cytotoxic lymphocytes. Important is that the response to first-line treatment is actually one of the most important prognostic factors. So it's very important that you have that you treat the patient good for the first in first line, because afterwards the prognosis is very poor. And another one is plasmablastic. I won't go into detail because Professor Castillo will talk about it in the next, but you know that PBL is typically seen in immune suppressive patients, also in immune competent. And what is striking in our population, but also in the literature, is that not the oral cavity, but the skin is the tissue which is most commonly involved in transplant-related PBL. And as you can see, and as you know, most cases are CD20 negative, making rituximab not a good treatment for these patients. The treatment will be discussed by Professor Castillo, but I think bortezomib is a very important cornerstone of this treatment, as patients who are treated in first line with bortezomib, they have the lowest risk for relapse compared to other treatments. And this is an encouraging slide showing that the prognosis of lymphoma has improved when you compare the first era of the transplantation compared to the second, which is of course due to better supportive care, but also to better treatments and to uniform treatments. And I think also, as already was said before, sometimes in the previous century, patients were sometimes treated by the transplant physician and not by the hematologist or the oncologist. So it's really important that we have a uniform therapeutic approach. And the last one I can be short is targeting EBV. So I already told that EBV, when it goes to the germinal center, it expresses latent antigens, but from time to time you have lytic replication. And actually the classical antiviral therapy doesn't work in PTLD because it's based on targeting those lytic replication. And so there has been interest in what we call the latent lytic switch. So it means that you give compounds which will cause upregulation of protein kinases, leading to lytic activation of the EBV infected cells. And when you have those upregulation, you can treat patients with antiviral agents. And there has been one promising phase 1/2 trial already from 2007 with arginine butyrate, which is a fatty chain acid, followed by which causes upregulation of this protein kinase and hence of the lytic antigens, followed by ganciclovir. I think it were 15 patients, of which 4 or 5 had PTLD, with promising results, but for one or other reason, this compound is not further investigated anymore. But there are other, and there are some trials which known and unknown products, for example, epigenetic therapies or hydroxyurea, bortezomib, may also be able to induce those latent lytic switch. And also, yeah, very interesting discovery was the fact that this is in Burkitt lymphoma. Burkitt lymphoma is associated with an latency 1 profile, that by giving this decitabine, that you actually upregulate other latent antigens. And so normally Burkitt lymphoma is not very sensitive for EBV-specific lymphocytes, but if you give that decitabine and you have an upregulation of the other antigens, it might be sensitive to EBV-specific lymphocytes. Of course, it's not tested in vivo yet, but it's an interesting approach. So these were the treatments we have, and in red you see which can be given to EBV positive and negative cases. Of course, adoptive immune therapy and targeting EBV is only applicable in EBV positive cases. And then we have, of course, the new classical agents, which we used to give in lymphomas or myelomas. This is just an example showing that BTK inhibition, P3K, mTOR inhibition, proteasome, checkpoint inhibitors, anti-CD30 can be given to PTLD patients from a theoretical point of view, with especially anti-CD30 and checkpoint inhibitors as very promising. But unfortunately, as you can see here, and I think you're all aware of that, most clinical trials do exclude some patients, and one of them are transplant recipients. So we don't have real trials with those agents, which also incorporate PTLD patients. And of course, you have to, maybe like, for example, with checkpoint inhibitors, you have to be careful for rejection, given the opposite effect you will have on the immune system. And this is just also an example with CAR-Ts. There are 2 series with 3 CAR-Ts, with 3 patients. And one is with Tisacel, showing actually very good results in 3 solid organ patients with EBV negative PTLD. But on the other hand, there was a case series with also 3 EBV negative solid organ PTLDs with Axicel, showing actually a high rate of adverse effects and no effect on the lymphoma. So it's really, at this point, it's not clear whether CAR-T are promising, and we need trials, but it will be very, very difficult. Retransplantation is also something which is often asked by our transplant physicians. There have been 2 databases showing that retransplantation is feasible and actually is not associated with an increased risk for PTLD. However, there was recently an other registry, an American registry, showing that patients, and it was only in kidney transplantation, that retransplantation in patients with a history of PTLD increased the incidence of PTLD from 0.8% to 2.8%. So it's not very high, but it's an increased risk, and we still need to be careful with retransplantation. Last word about prevention, prophylaxis, preemptive. The first thing is a vaccine. I can be very short. There is only one phase 1/2 trial with the GP350. That's that's an antigen on EBV, which causes the entrance into lymphocytes, but actually it showed suboptimal response. And as far as I know, there are no trials at this point with other EBV vaccines. Another problem is, who are we going to offer prevention, prophylaxis, preemptive therapy? We could say high-risk patients, but actually we don't really have a definition of high-risk patients. Which tests? I think we most commonly use EBV PCR, but as you know, there are different sources. You can do it on whole blood, you can do it on mononuclear cells, on plasma. There is no real cutoff. Do we have to look at one increased number or to an increase over time? And how are we going to perform preemptive therapy with reduction of immune suppression, with rituximab, with adoptive immune therapy? So it's very difficult. And this is an example. We can say 5% cumulative incidence is the limit to call a patient high risk. And so these patients will then be high risk together with the pediatric patients, and then the others will be low risk. And there are a lot of examples showing that if you have a risk strategy based on EBV, this is an example from Germany after hematopoietic stem cell transplantation, in which withdrawal of immune suppression with or without rituximab was given based on the increase of the EBV, showing that there was a decrease in PTLD compared to historical controls. And the same in heart transplant recipients. This is a French study showing that if you do reduction of immune suppression and in high viral load reduction of immune suppression together with rituximab, once again that you have a decreased risk compared to historical controls. A better strategy, and this is a nice, very recent example from Taiwan, showing from a large database in hematopoietic stem cell transplantation to really were able to categorize patients based on 5 risk factors, and maybe these patients, the high risk and the very high risk group, could be the most, could benefit the most from preemptive strategies. So this has led me to my conclusion. So this is our current concept of PTLD. And I think I won't repeat everything, but we have really made a lot of progress in, of course, in pathogenesis, in diagnosis, in staging, in treatment, in follow-up of patients with the possibility of retransplantation. But of course, we still need to do a lot of work. And I think one of the most important will be to really discover predictive and prognostic biomarkers for PTLD, which can be used to, on one hand, prevent PTLD, and on the other hand, to improve our therapeutic arsenals. And this will be based on next generation sequencing on cancer cells, but also by further investigating the tumor microenvironment. And of course, also important is the viral genome. Is EBV the only important virus, or are other viruses also not innocent bystanders, but also important in the pathogenesis of PTLD? And I really want to end with these slides because this actually explains the difficulty. Of course, the patient and his or her organ is of central importance, but actually around the patient there are so many people in PTLD. You have, of course, the families, you have the nurses, you have the physios, dietists, but from a medical point of view, you have, of course, the hematologist, the oncologist, the transplant physician, the genetician, the pathologist, the nuclear physician. So you have a real network, and it's really important. And I think that's actually the most important message. You really have to keep in contact with all these colleagues to ensure optimal treatment of your patient, because the lymphoma is one thing, but the patient, the graft are also very important, and we really need to take into account not only the lymphoma. So, and I really want to thank you once again for the invitation and for the opportunity to present this lecture here, and I'm ready to for the questions.
Thank you so much, Dr. Dan Derricks, for that lovely talk. Your research, advances, everything you put forward in these 45 minutes. We
Thank
have
you very much.
faculty here to ask you some questions, and we also have some questions from the audience. We'll start with Dr. Chirag. Chirag gets ready. I'll put a question from the audience. Do you see PTLD after autologous stem cell transplant?
Yeah, that's a very good question. You can't call it PTLD, but we have seen it, and probably it has to do with the chemotherapy. We will also discuss this for the next WHO book. Some chemotherapy, especially T-cell depleting therapy, can also give rise to EBV-driven lymphomas. So at this point, you're not allowed to call it PTLD, but I would call it an immune deficiency associated lymphoma. Yeah, sure. It's a very good question.
Dr. Chepsi.
Thank you, Dr. Dan, for this wonderful presentation. So I just have two queries. One, what are your thoughts on the high incidence of PTLD that you mentioned in pediatric versus haplo transplant? That is one. And second, regarding this waiting for this immunosuppression part, what is your practice? How long do you wait before you take the next call?
Yeah, so for I will first start with the second answer. For non-destructive lesions, we wait for 3-4 weeks and then do reevaluation. I have to admit that in practice, for polymorphic and monomorphic, we actually combine reduction of immune suppression together with rituximab in real life. The reason why is because often transplant physicians nowadays, they already have lowered the immune suppression during the diagnostic phase. So we often have patients who are referred with the lymphoma, and our transplant physicians, because they all are aware of the disorder now, they say, we have already stopped mycophenolate or azathioprine and reduced the calcineurin inhibitor. So that's the main reason. But there is no clear answer, and in practice we really start with rituximab also. And for the pediatrician, yeah, it's I think if you have an EBV negative child, I think this really is an indication to, especially the first 6 months, to do in the first 2 months every week EBV PCR, and afterwards every 2 or 3 weeks. Because it can be very explosive. We have now a patient, a young girl after hematopoietic stem cell transplantation, 2 months, who really has an impressive, rapidly growing lymph nodes with high fever. And you see her viral load in 1 week has really gone from 3 log copies to more than 7 log copies.
Thank you, Dr. Chepsi. One more question from the audience. In fact, you have answered that in your talk, but there is a question. What is your division between early onset and late onset? Cutoff? Yeah,
it's a good question, because in literature, there is discrepancy. It's 1 year, 2 years, 6 months, even 3 years. I have the habit to put a cutoff on 1 year, but it's you can debate on it. Yeah. Actually, because the second wave is actually mostly starting at more than 5 years. So it actually doesn't matter that much.
Second part of this question is that, is early onset PTLD mostly after hematopoietic stem cell transplant only?
Yeah, it's also a good question. It's in about 30% of the Solid organ transplantation, it's also early onset, 30-70, whereas in hematopoietic, it's 89 and 98%, for example. Yeah.
Another question is, should cancer survivors be dissuaded from being solid and other organ donors?
Can you excuse, should cancer survivors be?
Yeah, cancer survivors, should they avoid donating solid organs and other organs to recipient?
It's a very good question, and I think at this point, I don't know, like in Belgium, blood transfusion is not possible if you had cancer. So I think you should have the same rules for blood transfusion and for donors. But there is this discussion. There is, we often have the questions for example, a donor who died, who had a Hodgkin lymphoma at the age of 20, is now 60, and it's a difficult discussion, yes. But I think we need to be fair. If we refuse blood transfusion, we also need to refuse a dog. We are not, we have to pay attention that we are not putting the recipient into danger. Yeah.
Right. Chirag, are you ready with your question?
Yes, yes.
Go ahead.
Some issue with the video, but thank you for a nice talk. Some of this you have already answered, but on the EBV monitoring, you mentioned that there are a lot of issues with what type of the method we are using, but we have the plasma EBV monitoring. And is there a cutoff when you say that you need to treat or you need to have formal, lymphadenopathy and all? Yeah.
It's a good question. We don't have, we look at an increase. So if you have an increase of 1 log over 1 week, we will try to do an imaging. If the patient has no complaints or has complaints, then we do the imaging. Yeah.
Okay. Thank you.
Thank you, Chirag. Dr. Smita.
Yes, how do you do a response assessment in these cases, and what is the goal of treatment to achieve a CR or
The goal of treatment is achieving CR. Yes. Because for some subtypes, not for all, it's been shown that the first treatment, like for example, primary central nervous system, is important. There is some discussion when you still have some residual activity on PET-CT, for example. Probably if you lower the immune suppression and you keep on lowering the immune suppression, maybe it will disappear as well. But our goal is to achieve CR. Yes.
Thank you.
Because that's the negative predictive value is the most important for later recurrence and for survival.
Take a question from the audience again. Is it possible that you do not reduce the immunosuppression and treat the monomorphic PTLD with chemotherapy?
Yeah, theoretically it's possible, but I wouldn't do it, because when you have a patient with a lymphoma, it means that the patient is over-immune suppressed. You really need to lower it. But I agree that the data are less obvious with, for example, T-cell lymphoma and Hodgkin lymphoma. But I think if you have a patient with a lymphoma, it means that for one or other reason that the patient is over-immune suppressed, and then you need to discuss with the transplant physician. But it's sometimes difficult. But I would always lower immune suppression. Yeah.
The other question is, why EB virus positive PTLD not respond to antivirals?
Because it doesn't express that protein or thymidine kinase, which is typically for the nucleoside analog. So for acyclovir, ranciclovir. Actually, you can ask a pathologist to do lytic antigen on the biopsy. It's one example is the zebra antigen, and if it's positive, you can try antiviral agents, I think, but mostly they're negative in my experience.
Right. The other question is, what is your preferred regimen for PTLD Burkitt's lymphoma? Your preferred regimen?
Yeah, it's a good question. The problem is that most patients have kidney dysfunction because of the long-term use of calcineurin inhibition. So I use the protocol which is described in New England by Dunleavy for HIV patients. So it's based on EPOCH together with a double dose of rituximab and intrathecal administration. We have a few patients and they really respond well. They tolerate it well because high-dose methotrexate is only possible in a subset of patients because of the kidney problems.
One more question from the audience is, as PTLD can occur in EB virus negative individuals, then is the role of EB virus monitoring sufficient?
No, it probably is not sufficient, but we don't have any other. Maybe when we have other biomarkers, it might be good, but there have been some reports on, for example, serum free light chains and so, but actually none of them have been proven of value. But we hope by looking more into detail with NGS that we can find some biomarkers which might. That there has been a paper from the States looking at different viruses, and they found that the anellovirus, which is part of the microbiome, is associated with the poor prognosis. But if you look at that paper, I think it probably is just a reflection of immune suppressive state of the patient. So the higher your anellovirus burden, the more immune suppressed you are, and so it's more a marker of immune suppression and not of PTLD development. But of course, if you have more anello, you will have a higher risk to develop. But it's not a validated approach at this point. But it's a very elegant study, and I think we are working also on different viruses at this point. So,
right. Chirag, you have another question? No. Anyone else has a question?
Can I ask, sir?
yes, sure.
Yes, please.
Yeah. So, sir, one question is that, is there any relationship between the conditioning regimens that we are using, like ATG or T-cell depleting cyclophosphamide, which are producing higher chances of EBV? That is one question for the metabolic transplant. And the second is, sometimes in the Hodgkin's, when you do the transplant, patient might have the EBV at the day of diagnosis itself. So once you relapse after the transplant, can you whether it is EBV related PTLD kind of changes, or it is the relapse of the original Hodgkin, so that your treatment might change?
I think I understood the first question, but I think I didn't understand did anybody
so second question is,
yeah,
like that Hodgkin's disease day one might be associated with EBV.
Yeah.
And in case of relapse, we have done the transplant and the Hodgkin's has relapsed. So then we should consider it as a EBV PTLD or just the relapse of the original Hodgkin's, and how to go ahead with that. Yeah,
okay. So the first question is on the use of the chemotherapy in the conditioning regimen. So the most important factor is the use of T-cell depletion strategies. So if you use fludarabine in your strategy, or you use ATG, the post-transplant cyclophosphamide, which is now commonly used in mismatched transplantation, seems to be associated with a protection against PTLD. So we are also looking at our database, but so I think that the T-cell depleting ones are the most are the most important. And the second one is the Hodgkin lymphoma. Indeed, in post-transplant lymphomas, Hodgkin lymphoma are almost always EBV positive. If you have a Hodgkin lymphoma before the transplant and you have a Hodgkin afterwards, you can do yeah, some clonality to see if the or clonality is maybe not a good word, but to see if the lymphoma derives from the donor or from the recipient. So if it's a mismatch in gender, you can do FISH for sex chromosomes, for example, or you do HLA genotyping to see if the PTLD is deriving from the donor in hematopoietic stem cell transplantation or is from the recipient, and in that case, it probably is just a relapse of the prior. But these are very difficult if you have a patient with a lymphoma who is transplanted and develops a lymphoma. So you need to ask your pathologist to see if they can find some clues whether these are relapses based on prior samples or it's new. It's rare, but we also have had that problem. Yes, that's true.
Thank you, Dr. Dan. That's all the time we had to cover all the questions. So we are extremely grateful to you for educating us.
I think I see one hand, or is it?
Yeah, there is.
Sorry.
Okay, Dr. Kripa, quickly, your question.
Sorry.
Yes. Thank you, Dr. Dan. Is there any difference in the outcome and also incidence of infection in the EBV positive and EBV negative lymphomas?
It's a very good question. Actually, there have been discrepancy in the literature, but if we look at our own database, there actually is no difference in outcome, except for T-cell lymphomas. They really do poor. They can be EBV positive, they can be even negative. So it's more the subtype which impacts the prognosis compared to the EBV status, I think. But it's a question which we really need to look further on. Yes, that's true. Thank you.
Thank you, sir.
Thank you, Dr. Deris. So
thank you very much.
We are grateful to you for educating us with your lifetime research work. We really learned a lot today and a very interactive session.
Thank you very much and hope to see you in the future. Thank you very much.
Bye.
Bye.
It's time to introduce our second speaker. He is already logged in. So we now have Dr. George Castillo, Clinical Director, Bing Center for Waldenstrom Macroglobulinemia, Division of Hematological Malignancies, Dana-Farber, Associate Professor, Harvard, Boston. And he's going to speak to us on plasmablastic lymphoma. So over to Dr. Castillo.
Thank you, Dr. Agarwal, for the kind introduction and for the opportunity to be able to talk about a topic very dear to my heart. Plasmablastic lymphoma has been an interest of mine since my training years when I was at Brown University. And I've been, I think, lucky enough to be able to continue, working on this such a rare condition. And for the next 40 minutes or so, I will just walk you through the different developments in terms of what we understand about the pathology, the clinical aspects, and the treatment options for patients with plasmablastic lymphoma. And obviously, at the end, we'll open up for questions. I'm going to share my screen. There you go. So as I do in all my presentations, I always put my email address right there. As you can see, Jorge J_Castillo at dfci.harvard.edu. If you do have any specific questions about plasmablastic lymphoma patients, if you have any questions about any type of CD20 negative diffuse large B-cell lymphoma case that you would like to share with me, if you would like any guidance or help, please feel free to reach out to me at any time. I'm always happy to help in any way possible. So these are my disclosures. I'm going to just leave that table there for a few seconds. So I think plasmablastic lymphoma represents a diagnostic and a therapeutic challenge. So I think the first question that I'm going to try to answer here is, how do we diagnose plasmablastic lymphoma, in a way that we, believe is probably the most reliable way of doing this. So I want to just go back to the initial report on plasmablastic lymphoma. This was a French group that reported this in Blood in 1997. Initially, these researchers evaluated about 16 patients, of which 14 were men and 15 were infected with HIV. Now, interestingly enough, as you can see there, the majority of patients had a stage 1 disease, and that makes sense because these lesions tend to appear on the oropharyngeal area, so it's actually a little easier to detect. But there were a number of patients that were, had a bit more advanced stages. So when these biopsies were done, these lesions were taken out, we saw a very interesting aspect. We saw cells, I'm going to use the CD20 that is negative here. Essentially, just to go over the morphology of these cells, we can see, monomorphic, large cell, features, morphology. But with that nucleolus in the middle, in the center of the nucleus, and that really gives us an idea that this has a plasmablastic, immunoblastic, plasmablastic morphology. Now, interestingly enough, not only the CD20 was negative, CD38 was positive, very strongly suggestive of a plasmacytic differentiation, very high proliferation rate with a Ki67 in most cases over 80 to 90, over 100%. And interestingly enough, EVER was positive. This was done by in situ hybridization. And again, very much possibly related to the HIV infection, right? We all know, very aware after Dr. Dierek's presentation of the relation of these viruses when we talked about lymphomagenesis. So these patients were treated with chemotherapy and chemotherapy with radiation and some with radiation alone. But out of the 16 patients, 10 patients died, 2 were alive, and 4 were lost to follow-up. And the median overall survival is around 6 months. So really a little bit of a poor survival. However, it's unclear to how these patients were actually treated. What the status of their HIV infection was. So maybe the overall survival was not driven completely by the disease, but in part by the infection per se. And obviously that is a little less clear at the time of this publication in 1997. But we got the idea that we have a CD20 negative large cell variants with plasmacytic differentiation related to HIV and EBV with a poor prognosis. So at that moment is when plasmablastic lymphoma became a real thing and a distinct entity. So this is where I came in. I came in about 10 years later, coming out of my fellowship and thinking about what am I going to do to try to make a difference in academic life. So I decided to focus on this rare type of lymphoma, and this was my project when I was a hematology oncology fellow at Brown University. So what I did is basically I went back to 1997 and I reviewed all the cases that have been published in the literature with plasmablastic lymphoma, specifically HIV infected. And I came up with about 112 published cases, which is a sizable number. And just to get a sense of where are we in terms of the current status of how we see these diseases. And interestingly enough, I mean, it was a younger population, and again, very much reflective of the population that is infected with HIV. A majority were men, again, distinctive of an HIV-infected population. But interestingly enough, I started noticing that the CD4 count were not that suppressed compared to what we see in patients with diffuse large B-cell lymphoma, for example, or primary effusion lymphomas, in which the median CD4 count cells are very well below 100, sometimes below 50. There was a big range, however, between 10 and 500. I mean, most of these patients had a median of 5 years of HIV infection, some of them 20 years. And I mean, most of them were on active heart therapy. Now, in terms of the staging, we saw a very nice dichotomy. We saw that there was a large number of patients, almost half of them with localized disease and half of them with more advanced disease. So it looks like there was very little intermediate diseases. Either you caught it very early or you caught it very late. And as we saw previously, the oral area seemed to be preferred, but it was not unique, right? So we could see here that there was some GI tract involvement, some lymph nodes, and there were other extranodal in areas, specifically in the skin, in the bone, in the testes. I mean, basically any organ could be affected by this at a lower proportion than the mouth, but the mouth remained to be very important. So I think what we learned from this is that plasmablastic lymphoma can be seen outside of the mouth, and that can complicate things a little bit in terms of the diagnosis. In terms of therapy, these patients received a number of different chemotherapies. Some of them received CHOP without any rituximab because there's no CD20 expression. But at the end of the day, more than half of the patients had passed at the time of the publication, with a median overall survival of about 9 to 12 months in most patients. This is more typical. I'll be more, looking more into the plasmacytic differentiation markers. Again, we see the H&E here with the classic immunoblastic, plasmablastic morphology, CD20 clearly negative, CD138 in MUM1. So not only CD38, but CD138 in MUM1. These are classic plasmacytic differentiation markers. And we want to see how that translates into how we can treat these patients later on. MIB1 is like Ki67, proliferation rates very high. And again, an EBER-ish in situ hybridization that was positive. So I think we can make the diagnosis of plasmablastic lymphoma in that matter, having a high suspicion and understanding what the morphology of these cases could be. Now we understand a bit more about diagnosis. What is the prognosis of these patients? This was my initial question as well. My second question after how we are doing with these patients is how these patients are surviving or not. So from that initial database that I put together, I basically selected the patients that were actually treated with chemotherapy, just separated about 70 patients, all treated with just chemotherapy, with what we believe is the actual appropriate treatment for these patients. And then we saw how they did. Again, very similar distribution in terms of the age of the patients, as well as the CD4 counts in the clinical stage, as previously reported. So it was not a population too different than the initial population that we were looking into. Interestingly enough, we saw that the complete response rates to CHOP and other treatments was really poor, about 50%. That's not a great response, complete response rate, as you can see. And obviously, partial responses about 30, in about 20% of patients were refractory to therapy right from the get-go. The median the median overall survival on these patients was 14 months. These are patients treated with formal chemotherapy, and we saw that the outcome was actually really poor on these patients. In terms of prognostic factors, we looked at clinical stage, and it looks like patients with more advanced disease did worse than patients with earlier disease, and that is something that we have seen repeatedly along the way in aggressive lymphomas. And obviously, obtaining a complete response was actually a better prognostic marker than not obtaining a complete response. But even in the patients who got into a complete response, the risk of death, up to 4 years out was about 40%. And again, looking at the treatment options, we divided the chemotherapeutic regimens between CHOP and CHOP-like versus more intensive than CHOP. And that included EPOC and hyper-CVAD and all these other treatments, CODOX and BIVAC. And again, really, we did not see any overall survival benefit between either doing CHOP alone or CHOP-like regimens versus more intensive regimens. So what I learned from this paper from this study was that really the survival, even when we treat these patients, is short. And it seems to me that really it didn't matter what type of intensity of chemotherapy you're doing to these patients. There are no major differences in terms of survival in patients with plasmablastic lymphoma with HIV. So once we started getting into this interesting topic, I said, so what about the HIV negative patients? It looks like there was a bit of a neglect towards HIV negative patients. So I carried a bigger literature search with some colleagues now. They were also interested on this topic. And we actually were able to collect over 220 patients now. It was up to 157 patients with HIV positive disease and about 71 patients with HIV negative disease. This is a paper that came out about 2 years later from the initial paper that I published on the initial 112 patients that I got together. And we started seeing that there were real evidence of HIV negative patients with plasmablastic lymphoma. Now, how do we differentiate HIV negative plasmablastic lymphoma from an ALK positive diffuse large B-cell lymphoma or from an extranodal, extracavitary primary effusion lymphoma? We basically make sure that there were no HHV8 cases in this There were not ALK positive cases in this. There were not patients with history of Castleman's disease in this. So these are purely HIV negative, HHV negative, Castleman disease negative patients with ALK negative. So making sure that it's not any of the other, CD20 diffuse large B-cell lymphoma variants that we know about. So this was a kind of a pure group of people. The best we could, obviously, with the caveats of being a retrospective study and a literature search for that matter. But then we started seeing here there was a different profile. We actually saw that patients in the HIV positive group, the median age was 39 versus 58 in patients with HIV negative disease. As you can see here, there's a statistically significant difference. And patients older than 60 were younger than 60 were about 99% of the HIV positive patients, but about 50% of the HIV negative patients. So there's a difference in terms of the age of these patients. And the distribution in sex is different too. Men, about 80% if it's HIV positive, but only 60% is HIV negative. There were no differences in the distribution of the staging, and you can see as well kind of a diversity of early versus late disease stage. And when we think about oral disease, 60% of patients with HIV positive have disease in the mouth, but about only 16% with patients with HIV negative disease had disease in the mouth. So it looks like even the clinical presentation of the HIV negative plasmablastic lymphoma was actually different than in patients with HIV positive disease, and this difference was also statistically significant. There were no difference in terms of bone marrow involvement or B symptoms. Now, in terms of therapy, they received similar therapies, chemotherapy in 80% of the times, no chemotherapy in about 20% of the times. And the responses were actually better on the HIV positive group with about 55% complete response versus about 42% in HIV negative disease. And that difference was also statistically significant difference. So we're starting to get a sense that these patients with HIV negative disease are a little bit different than the patients with HIV positive disease. And now, pathologically speaking, there seem to be also some differences. CD20 expression could be found in some cases with plasmablastic lymphoma, very faint, but it's there, 17% of the cases. While in HIV negative, we don't see any CD20 expression whatsoever. CD56 expression, which is a natural killer cell marker, and I think provides some more aggressive nature of the biology of the disease. 67% of patients with HIV positive versus 6% patients with HIV negative disease. And EBV expression, 82% in patients with HIV disease, expectedly, but only 45% in patients with HIV negative disease. This is also a difference. So I think HIV negative starts distinguishing itself as a separate entity than HIV positive plasmablastic lymphoma. And not only that, when we looked at the overall survival, again, around 12 months, which is what we have seen before, but when we separate between negative and positive, it looks to me that the negative patients, HIV negative patients, have a little bit lower, poorer outcome than in patients with HIV positive disease. So my conclusion after this is, yeah, there is HIV negative plasmablastic lymphoma, and these patients seem to actually have a worse survival. Until this moment, all these was retrospective data, literature searches that I've been doing by myself with some colleagues. And I decided to run a specific retrospective study of original data. So I contacted some colleagues of mine in different parts of the United States and in the world, and we were able to put together 50 cases with HIV plasmablastic lymphoma. But we were very specific that these patients have to have the disease. They have to be on HARTs, because I think highly active retroviral therapy plays an important role on how these patients are going to end up doing. And these patients have to have received some type of treatment for their disease. So we can see here, this is 50 patients, original data. Majority were young, majority were men. And actually, majority, about 50% of the cases, 40% had a CD4 count level over 200, which is also within normal limits. And clinical stage, majority were actually advanced, a little bit less early disease in these specific situations. And the majority got treatments like CHOP-like regimens versus other regimens. And we can see here the response to treatment. The complete response is actually 66%, so it's a little bit better than what we have been reported previously. But about 2/3 of the patients already died by the time of the report of this case, and the majority died from lymphoma or infections. Again, we were making sure that there were no ALK positive cases here. There were not HHV8 positive cases here to rule out other potential CD20 negative variants here in this data. So our overall survival in this group, chemotherapy treated, heart intervened, about 11 months, still very poor. Patients with IPI scores on the low side did better than patients without it. But really treatments in terms of the intensity, there were no major differences here either. So even with chemo and with heart, plasmablastic patients did not do too well. So now we just need to acknowledge, right, that this is a very difficult disease to treat, at least with poor response rates and poor survival. So then how do we improve? How do we improve the outcomes in patients with plasmablastic lymphoma? That was the question that I started putting myself in about 2015 when I started looking at these patients. At that time, I got invited to write a paper for Blood in this topic, and I was honored to do that. So the topic was the biology and treatment of plasmablastic lymphoma. So for that, I needed to go back into understanding, I think, the biology of the disease just a touch better to see what can we do different on this type of patients. So these plasmablastic cells are B cells that have already undergone antigen exposure in the context of the germinal center. So these are post-germinal cells that actually had undergone antigen presentation. They have had all these CD4 helper survival signals. They have undergone somatic hypermutation and also undergone high immunoglobulin class switching. Now, interestingly enough, what we tend to see in these cells is our expression of plasmacytic markers like MOM1 and IRF4, but also something that we haven't talked about much yet. We saw a lot of expression of MYC. Actually, MYC gene rearrangements were seen in over 30 to 40% of the cases with plasmablastic lymphoma. So kind of thinking about how this is potentially a hybrid between a myeloma and Burkitt's up to some degree, so that's where when I was trying to get a sense of where is the cell of origin for this type of malignant cells. And I think that's probably where we are in this type of cell. So for that, we kind of understood that there has to be some mechanisms that induce negative selection on these patients, and some mechanisms that induce positive selection on these patients. And I think a central player on this is not only obviously the infection by HIV, by EBV, that induces specific activations of nuclear factor kappa B and all that, and decreases apoptosis, but also there is a proliferation issue with the MYC translocations. So I think the central player here, at least from my perspective, was an overexpression of nuclear factor kappa B as a marker of plasmacytic differentiation. So based on that understanding, I started thinking, so what if we added an agent that was potent in terms of blocking nuclear factor kappa B? And at that time, one of the most important clinically used medications was bortezomib. And it did make sense in my mind, because not only we're blocking nuclear factor kappa B activation with bortezomib, also bortezomib seemed to have had a good effect on patients with myeloma because of the plasmacytic differentiation, and specifically in patients with myeloma who had deletions 17p with p53, and that has also some, it kind of ties up together with the overexpression of MYC in those patients. So in my mind, it did make sense that we could potentially add, an anti-myeloma agent to a lymphoma regimen, and try to see if we can get some benefit from that. But that suspicion arose from understanding the pathology and understanding the biology of the disease in terms of trying to move forward with treatment interventions on these patients. So based on that, I started going back into the literature and doing what I do well, which is just mine the literature for data. And I started seeing some cases in which bortezomib had induced responses in patients with plasmablastic lymphoma with and without HIV. This case from 2009, we can see the PET-CT on this case on the left. And after therapy with bortezomib alone, we see some response. Now, the responses were minor, they were transient, they were partial, but they were there, which means that there is a part of the clone of plasmablastic lymphoma that is sensitive to proteasome inhibition. This is a second case by my colleague, Nahle Saba. In this situation, we see here a big, large pelvic mass on this patient that in therapy with bortezomib, and this is relapse disease, single agent, we see a fantastic response, really rapid, but also transient, and then the patients almost always continued progressing, and the disease ends up killing the patient. We have another case of an oral agent here, again, oral case. We have a very large destructive lesion on the maxillary area of this patient. And with therapy, the bortezomib induced a very nice therapy response on this as well. So then I started thinking, so if I were to add bortezomib to chemotherapy, would I be able to improve the outcomes of patients with plasmablastic lymphoma? So that was my initial thought. And that prompted a study that included only 3 patients as a proof of concept that I carried when I was at Brown University. And we just put three cases here. 2 of them were HIV positive and 1 of them was HIV negative, because I thought it was important to have at least some HIV negative representation here, just to make sure that this is something that could potentially be, applicable to both different types of plasmablastic lymphoma. So the first case is a 40-year-old man, HIV positive, presenting with a good CD4 count to 90, stage 4 disease. The patient had pharyngeal and rectal disease, as you can see on the PET-CT. This is the case number 1. On the PET-CT down there, we see the uptake on the pharynx, as well as the rectal area. We see the lesion in the rectal area here. There was MYC positivity expression, about 60%. EBER was positive. The second case, it was a 36-year-old man, HIV positive. CD4 was 34, was low. Stage 4 with rectal and lung nodules, EBER positive. And the third case is actually a very interesting case because it was an HIV negative patient. Actually, he was a physician. He was a gastroenterologist. He is a gastroenterologist. And he started noticing that he had trouble going to the bathroom. And then he went one weekend to his own office, and he basically scoped himself, and he found a colonic mass. And then he went to see somebody. That biopsy was done, and it was shown to see this plasmablastic, and then he contacted me, and so I met him after the whole process. But this is probably one of the few or unique self-diagnosed plasmablastic lymphomas that I know about. So these patients ended up being treated with dose-adjusted EPOC in combination with bortezomib. In these patients, what I was doing was intravenous bortezomib on days 1, 4, 8, 11 with the EPOC as planned. In these regimens, in this patient, actually, I was doing intrathecal chemotherapy with each cycle of EPOC, and that was the regimen that I put together at the beginning. We found ourselves with some trouble with neuropathy. We found ourselves with some trouble with thrombocytopenia. Usually day 11 of bortezomib couldn't be given because of severe thrombocytopenia that these patients were getting. So there were some issues with the whole process. The HIV patients continued their heart. And at the time of this report, which came out in 2015, our patients, one patient was alive for 4 years. The other patient was alive for over 3 years. Another patient was alive for 2.5 years. So it seemed to me that was a very suggestive of good activity of adding bortezomib to dose-adjusted EPOC on these patients. And then since then, we have had other groups that have been doing similar work. This is a Spanish study of 2 patients in which patients got bortezomib and CHOP. This was not EPOC, it was CHOP. And again, sorry, 3 patients. 2 patients were alive at 12 and 24 months, and 1 patient died by 12 months. You can see here, these big rectal masses, very typical. Pre-treatment, post-treatment, the PET-CT kind of very much responded there. So very interesting aspect as well. And there was one case in which EPOC was given with bortezomib. Again, you can see the PET-CT, disseminated disease after treatment was completed, and at the follow-up at 2 years, the patient was free of disease. So we felt that this intervention made actually some sense, and that we could potentially add bortezomib to EPOC in patients with plasmablastic lymphoma. So that led us to a larger study. So I've been basically treating plasmablastic lymphoma in that manner in my clinic. And this is a study that we published a couple of years ago with 16 patients that have been receiving bortezomib and EPOC in the frontline setting. And again, you can see here, the majority were men. This includes patients with and without HIV disease. HIV infection was actually only 6 out of the 16. The majority were HIV negative patients. There were no CD20 expression, and again, no ALK, no HHV8, making sure that we're ruling out other processes. We do see some MYC rearrangements here in about 80% of the patients. EBER was positive in 64%. So, a classic, typical, population, I would say, of patients with plasmablastic lymphoma. And these were our results with a median follow-up of about 4 years. We have a survival of about 60% at 4 years, which is very different than the curves that we showed earlier on today. Now, interestingly enough, in supporting what we have seen previously, this is all original data, we see the patients with HIV positive disease end up really not succumbing to their disease anymore, compared to the patients with HIV negative disease in whom there have been more problems, and usually the median survival is reached at about 4 to 5 years. And again, the IPI score low is a good predictor of how well these patients are going to be doing compared to the patients with high or high intermediate disease. Now, there is a role, I believe, on transplanting these patients with plasmablastic lymphoma. This is a review that Monser Al-Malki, now at City of Hope, did. We did this together when we were in Providence in Rhode Island, and we put these cases together. And we were able to see that there were some patients who benefited from a beam conditioning regimen, so a classic lymphoma beam regimen, in which then, followed by a complete response and then a survival for, a number of years. So based on everything that I have presented to you, this is essentially the way I approach plasmablastic lymphoma. So if I see somebody that seems to have a plasmablastic lymphoma, first I make sure that the patient doesn't have ALK, the patient doesn't have HHV8, so I can qualify my patient as a true plasmablastic lymphoma. And then I see if the patient has HIV or doesn't. For HIV disease, if there's an early stage, I actually go with VCHOP. I don't go with VEPOC. I think VEPOC might be a little too much, but you could choose to go to VEPOC for 4 cycles. I do add radiation. I think radiation in this setting is very important in the early stage, very mimicking what we do with diffuse large B-cell lymphoma. And I make sure that these patients do continue on their antiretroviral therapy. If the patient has advanced stage, this is when I go with the EPOC times 6 cycles, continue hard. And if there was too much of a bulky disease, maybe I will consider radiation at that time. But I do not radiate too many people now. Now, over the years, have been slowly using less and less intrathecal chemotherapy for prevention of CNS disease. I do not see that actually very much. None of the 16 patients that we presented in 2019 actually had intrathecal interventions. So that is not something that I'm currently recommending based on our experience. Now, if the patient has a complete response, we can observe those patients. Those patients don't need to have a frontline transplant, and then probably end up doing well. If there is a less of a complete response, then I think a salvage chemotherapy, and we'll talk about that in a second, followed by autologous transplants actually does make sense. And this is a difficult population of patients because they end up, most of them do not do well. Now, if a patient is HIV negative, obviously I follow a very similar approach, VCHOP times 4 with radiation. For early stage, and for advanced stage, I do VEPOC times 6 with or without radiation. This is where it's a little bit different. If the patient gets into a complete response, I think I would at least think about potentially doing a transplant on these patients. These patients tend to have a much worse outcome, as we have seen. So if the patients are young and willing, sometimes we do move forward with an autologous transplant on CR1 on these patients. If less of a complete response, then we do salvage chemo and ASCT, an autologous transplant. So what do we do for relapse disease? Relapse disease is very complicated. If a patient with plasmatic lymphoma, relapses, it's very difficult to salvage those patients. So I've been trying to see what we can do on this type of patients. This is a case in which we have a transformation to plasmatic lymphoma in CLL upon ibrutinib therapy. This is just a case of thinking what could be done. In this case, daratumumab was given in combination with COP, and that induced an actually complete response. But then right before the transplant, the patient relapsed and died shortly. But that gives us an idea that daratumumab in combination with chemotherapy could potentially be an efficacious treatment for patients with relapsed plasmablastic lymphoma. This is another study in which the patient actually got bortezomib, lenalidomide, and daratumumab, so a classic myeloma therapy followed by radiation. The patient got a CR in PET-CT, as you can see here, a CR in December of 2017, and then the patient had an haplo stem cell transplantation that so far seems to be in a good situation currently. So there is something to anti-CD38 therapy. So this is a case of my own clinic, a 55-year-old man, HIV positive, presented with right lower quadrant pain. You can see a very big mass, kind of invading into the kidney. The pathology was classic for plasmablastic lymphoma, with the exception that was no EVER, even though the patient was HIV positive. These things happen sometimes. The patient, we adjusted the patient's heart and we give them 6 cycles of VEPOC. Patient got into a CR and he was doing great. But then 2 months later, he presented again with some right flank pain, and we can see the PET-CT now showing some uptake there, suggestive of relapse disease. We actually gave the patient ice with daratumumab. So we gave the patients ice the way we typically would give it for patients with diffuse large B-cell lymphoma, and we would add daratumumab once, the regimen that we follow in myeloma, once a week at 60 milligrams per kilogram intravenously for the first 8 weeks of therapy. The patient got into a CR, and then we get him into an autologous transplant, and actually 6 years out, and the patient is continues doing well. So I think daratumumab in combination with chemo, followed by transplant in the patients who can tolerate it, makes sense. And there's some data suggesting that this combination could be effective. Now, there is an American study ongoing in which they are adding daratumumab to chemotherapy in the frontline setting for patients with plasmablastic lymphoma and other CD20 negative lymphomas. So I think that the results of that study will be very interesting in the future. And then let me present you with another case. A 79-year-old man, this was recently published, 79-year-old man, HIV negative, presented with a yellow nasal discharge and progressive left-sided facial numbness, and the cheek was actually bulging. You can see here how the CAT scan shows a destructive lesion on the left maxillary sinus there. A biopsy was done, and we see, the H&E, very plasmablastic features here, CD138 positive, Ki67 positive, EVER positive. So a classic plasmablastic lymphoma stage 1. We actually give this patient VCHOP for 4 cycles, and we wanted to do radiation. He got a CR after the 4 cycles. We wanted to do the radiation based on our plan, but then within 4 weeks, the patients actually had recurrence of disease. This patient, we actually gave him daratumumab, lenalidomide, dexamethasone as salvage therapy, but the patient did not respond to that. And that may be where daratumumab chemo might be a better option than just giving, myeloma regimen alone. You can see here at relapse, very strong FDG avidity on the maxillary sinus there. And again, what we did here, and here on the right, is actually PD-1 expression. So we were like, so what are we gonna do? We're not gonna transplant this guy, 79-year-old. We're not gonna give him high dose chemotherapy. Can we use anything else out there that is not daratumumab or bortezomib or lenalidomide? So we actually run a PD-L1 expression on these malignant cells. And as you can see here, very high expression, not only in the malignant cells, but also in some of the on the tumor, associated macrophages as well. So we got an idea that maybe we could try a PD-1 inhibitor or a monoclonal antibody on these patients. So we decided to start this patient on pembrolizumab. So we started pembrolizumab, we radiated the patient. So I think it's a combination of pembro and radiation. And the patient received pembro for about 18 cycles, and he was getting imaging every 3 months. And we were seeing, as you can see here, after 6 cycles, this is a PET-CT, the mass still there, but the metabolic activity is very much decreased. So he continued for 18 cycles, and he had some complications. I mean, this is not a very easy regimen to give, but the patient had recurrent UTIs, pneumonias, he had an episode of shingles, ophthalmicus, and at some point, he became very short of breath and started developing lower extremity edema. And an echocardiogram was done and showed that ejection fraction was 10%. That was 18 months or 18 cycles into pembrolizumab. And we felt that maybe this was secondary to pembro, so we stopped it. So we stopped pembrolizumab, and we stopped pembrolizumab about a year ago. And this is his PET-CT 12 months after pembro. So we see there's no evidence of a mass on the maxillary area. There's no evidence of FDG ability anywhere else. This patient is in a complete response, 36 months from the initial diagnosis. And now about a year after pembro, his ejection fraction has improved now to 45%, and the patient is alive and well. So I would like to conclude this presentation by bringing you some specific thoughts that I have. I think plasmablastic lymphoma is truly a distinct entity pathologically with initially a poor prognosis, associated clearly with HIV infection, with EBV infection, with mixed gene rearrangements. Plasmablastic lymphoma can occur outside of the mouth. It basically presents anywhere in the body. The mouth is still preferred in the HIV patients, but much less preferred in HIV negative patients. Now, HIV negative patients might have a worse survival, based on what we're seeing, even with the VEPOC treatment that we're using. Now, based on our experience, bortezomib with chemo might improve the outcomes in patients with frontline. I continue treating these patients. At some point, I will have larger data besides the 16 patients that we have treated or presented 2 years ago. But I think there is something to bortezomib and chemotherapy on these patients. And for the relapse setting, I think considering anti-CD38 or anti-PD-1 monoclonal antibody therapy might be of value. Specifically, if we're going to combine with chemotherapy, I think anti-CD38 with chemo followed by transplant in patients who are going to go for transplants, and probably the patients who are not going to go for transplants, anti-PD-1 therapy might be reasonable as long as there is anti-PD-1 or anti-PD-L1 expression in the malignant cells. And with that, I really want to thank you for your attention, and I remain available for any questions you may have on this topic.
Thank you, Dr. Castillo, for presenting this lifetime work of plasmablastic lymphoma, how the story evolved, how you took interest, and where you have reached. Thank you so much for putting it across.
No, thank you.
I have myself one question. Are you offering autologous transplant to all your patients, irrespective of the nature of response?
I do recommend transplants almost exclusively in patients who get into a complete response and patients who are HIV negative in the front line. So if you are in a complete response 1, CR1, if you're HIV negative, I'm offering transplant to those patients. For HIV positive, I am not. In the relapse setting, I offer transplant to everybody. I think as long as they are candidates for a transplant, as long as they are able to tolerate the transplant, I think it's a reasonable approach to follow, specifically in patients who have got into a CR. Now, if you have gotten into a PR, into a partial response, there's still a little bit of a disease there, and you already are in the relapse setting, right? If you're already in the relapse setting, what I have done in some cases is I radiate that spot if I can, and then I move into the transplant. So I do not discard that possibility, but I think the metabolic activity will have to be really, really decreased, right? So I need to make sure that the patient is truly, chemotherapy sensitive before I move ahead with transplant. But I would tend to radiate first. In the frontline setting, if the patient doesn't have a great response, then I move into a second line setting and then a transplant afterwards.
My second question to you is, besides bortezomib, are you using any other myeloma drugs upfront in the first line?
That's a good question. I haven't, and the main reason is because I cannot get them reimbursed. So I do think that carfilzomib could potentially have a great, activity in that setting. I think daratumumab can have a great activity in that setting. Maybe even ixazomib can have a great activity in that setting. But it's much more difficult to have them reimbursed for diagnosis of plasmablastic lymphoma. At least with the data that we have in others with the combination of bortezomib and chemotherapy, I think that we have had fewer problems trying to get insurances to pay for that. Having said all that, we have had some situations in which we want it and the insurances have said no, and we have to give the patient just chemotherapy without proteasome inhibitors or any other intervention. But yeah, I think there's a chance that other agents could be as good as, if not probably better. But we have these challenges with these newer medications in terms of reimbursement.
Do you strictly follow CHOP versus EPOC for localized versus spread out disease?
I try, but I mean, nothing is 100%, right? There's a little bit of a gray zone areas everywhere. So if a patient tends to be on the older side, and I think EPOC is going to be too problematic for them, I tend to use CHOP in that scenario, even if the patient has advanced disease. And sometimes when the patient is young, and I really want to give the best option for the patient to get better, I do even EPOC in the early stage disease. So I mean, it's not 100%, and I think age and performance status has a lot to do with that decision. But yeah, so that's what I tend to do.
If it's a young fit person, it is DA EPOC or only EPOC?
DA EPOC, and with the bortezomib added to it.
Right. So we have questions from our faculty here, Dr. Kripa.
Sir, I'm just curious to know, in 2010 publication of yours, Leukemia Lymphoma, there was a comparison between no chemotherapy versus chemotherapy. A patient who received chemotherapy versus no chemotherapy. I'm just wondering, patient received heart and observation alone. Is it so, sir?
Yeah, so there are actually two case reports showing that spontaneous regression of plasmablastic lymphoma just with antiretroviral therapy. But the cases there, the patients were having the plasmablastic lymphoma and they were not on heart. They have never received heart. And then you start the heart, and then maybe you can see that. Nowadays, I don't think that would apply, at least not in the United States, because everybody gets, antiretroviral therapy. So I wouldn't rely on that, specifically, at this time.
And one more question, sir. Sir, if it is Iverish positive or HHV8 positive, will you treat with any viral-directed therapy, viral-directed agents for a patient who's having high titers or high interleukin-6 levels or anything like that?
Yeah, so I mean, if the patient has HHV8 positive disease, then I don't call them plasmablastic lymphoma anymore. I think those patients might have, HHV8 positive diffuse large B-cell lymphoma related to Castleman's. They can have maybe an extracavitary primary effusion lymphoma. So my approach, I mean, what I have done in a few cases, I mean, this is obviously much more rare than plasmablastic lymphoma. So I have actually treated some primary effusion lymphomas and even some ALK positive diffuse large B-cell lymphomas with bortezomib EPOC, and I have not used any antiretroviral or anything like that at this time. If a patient has active Castleman's disease, then that might be a different story. I have not had a case like that yet, but I would imagine that if a patient presents with active, lymphoma with active Castleman's, I will probably add, an IL-6 blocker like siltuximab or something like that to the regimen. But I have not had the chance to do it because I have not had a patient in that scenario yet.
Thank you.
Dr. Sanjeev.
Good evening, sir. Nice lecture. Sir, my question is, what kind of salvage therapy you prefer for patients who doesn't show complete response, whether monoclonal antibody-based salvage or only chemotherapy?
Yeah, so for salvage, I tend to use daratumumab ice. That's what I tend to use. But I have had some patients have had daratumumab ESHAP, and that has been okay. So I think pretty much I would say any regimen that you would like to use, a lot of people use GDP, GMOX, ESHAP, DHAP, ICE. I think any of these relapse regimens can be easily combined with daratumumab. because you just give daratumumab once a week, for 8 weeks. And, within 8 weeks, most of the times, if the patient is responding or not with at least 2 cycles of whatever regimen you want. And therefore, you're going to go into transplant very early on or not. So you don't have to worry too much about, how much daratumumab you're going to give. You just give it during the induction, and then you move into the transplant. But yeah, my preference is ICE because I have more experience with it. But I can see how you could combine it with any other regimen you would like.
Yes. Thank you.
Dr. Asif?
Sir, we use infusional dose-adjusted epoch in patients of plasmablastic lymphoma. I have encountered 2 patients who have diarrhea, and I assume that those diarrheas might be because of the associated heart, which we use as amtricitabine plus tenofovir. Now, in a situation, we had to stop the heart to continue chemotherapy. We had a problem in deciding the cutoff, CD4 levels at which normally we, are very much comfortable in stopping heart when the CD4 count is more than 200. So any such situations that you have encountered, or do you stop heart in the complications, or do you stop chemotherapy? I mean, stopping chemotherapy must be a more difficult decision.
Yeah, so if there is any side effect that we believe are truly related to heart, you can stop heart for a little bit. I have no problem stopping that. Actually, if you remember the initial studies from the NIH and all that, they actually stopped heart when they were given epoch, right? So I don't have any issues with stopping heart. Now, I try not to do it, right? So that's my own practice. I try to kind of deal with the side effects the best I can, and it's a little challenging, but you just try to deal with it, the best you can. I try not to do that. But if you are in a situation in which you have to stop heart, then if the patient's CD4 count is over 200, I wouldn't sweat it much. I would just stop it and continue the treatment for the chemotherapy. If the CD4 count is less than 50, I would probably not stop it. And if it's between 50 and 200, then I will kind of play around with it, to try to. I don't think there's any data to suggest that there's one way to go that is better than the other one. But yeah, I try to keep the intensity of heart and the chemo. One of my mentors in HIV lymphomas from years ago, he said, you know what, antiretroviral therapy is a very anti-lymphoma regimen. So I try to keep the intensity the best I can.
Chirag?
Yes, very fascinating talk. Now you mentioned using the bortezomib day 1, 4, 8, 11. How many patients are able to tolerate that and complete 6 courses? Anything we need to keep in mind so we can complete it?
So yeah, I mean, that's a good point, and I think I kind of neglected to mention that in the second paper with our second experience, we actually moved towards subcutaneous bortezomib instead of intravenous bortezomib. So that makes things just a touch better in terms of the neuropathy, in terms of the thrombocytopenia. Now, if there is any neuropathy, I actually drop the vincristine. I do not drop the bortezomib. The vincristine is the one that goes out of the picture. I keep the bortezomib, and only if the neuropathy progresses on bortezomib alone, that's when we start decreasing the dose from 1.3 to 1.0 to 0.7. Now, I have in some kind of older patients, I've been doing weekly bortezomib instead of twice weekly. 1, 8, 15, 22. I just go it throughout without resting, just once a week throughout the entire duration of the treatment. But I have not done that too often. Most of the patients tend to be on the younger side a little bit. So yeah, 1, 4, 8, 11 subcutaneous. Just watch for neuropathy, drop the vincristine, watch for the thrombocytopenia around day 11. If you need to hold it, then you hold it. I usually hold it if the platelets are below 50. If the platelet is 51, I give it. If the patient is 49, I don't give it. But again, it's just a matter of practice.
Two questions from the audience. Some of them are related to the PD-L1 expression. Do you look at the expression before giving Pembro?
Well, I mean, we The thing is that there's some data already showing that in PBL there is PD-L1 expression and PD-1 expression. I think you could, in theory, say, well, if I know that the large majority of these patients already have this expression, then why do I have to check it? I just give it, right? So you can actually look at it that way. In my case, we wanted just to make sure that we are at least have the target of what we want to be attacking. But based on the data that is mounting, you could potentially just treat with a PD-L1 inhibitor if you can get it, without having to check the PD-1 or the PD-L1 expression, because I think there is kind of universal expression in that specific sense.
Probably then this gets answered. The other questions are, is PD-L1 expression dependent on HIV positive versus HIV negative PBL?
That's a great question. I don't think we know very well about that because most of the data that is out there is actually cell lines, and not really patient cells. But we do have a number of samples that actually have shown PD-L1 expression. So this case that I presented, for example, was an HIV negative case, right? When in the prior cases have shown that HIV positive, EBV positive cases are the ones that have the PD-L1 expression, right? So my sense is it's probably universal. Again, hopefully we'll have more data coming up to be able to say that with category. But my sense, my opinion is that there is a universal expression of PD-L1 in PD-1.
Another question is again whether it is related to EB virus positivity.
What was the question? Sorry, I think I missed.
PD-L1 expression, is it related to EB virus positivity?
So we thought that was the case, right? But then we see this case that has no EBV infection, right? HIV negative, EBV negative, and then the PD-L1 expression is there. So I don't think we can categorically say that is uniquely related to it. I think maybe more likely to be related to it because of the pathophysiology of how the EBV infection promotes PD-L1 expression. But I don't think is unique to that. And patients without HIV infection or EBV infection can also have PD-L1 expression.
There's a question that, like myeloma, do you have anything like maintenance therapy in these patients?
Yeah, typically not. And I think the reason I don't feel that is something that we need to do is because in diffuse large B-cell lymphoma, in the classic one, I mean, the couple of studies that have been done with maintenance haven't shown any benefit. So I really feel that there might not be a benefit of maintenance on this disease either. But again, I think it's a very good question for a clinical trial. If you can get the numbers to prove that. Yeah.
Another question is your selection of CHOP versus EPOCH dependent on CD4 count?
Not necessarily. I think it's more dependent on the performance of the patient and the patient's age and how much toxicity I think they might have with the regimen and the stage of the disease. So I think I have to try to have those two things into account. I don't think the CD4 count per se plays a role in my decision making there.
Another question is, in a newly diagnosed patient of HIV as well as plasmablastic lymphoma together, do you wait for treatment of either of the two or start both the treatments together?
Both. Boom.
Right.
Yeah. That's the best recommendation I can give you.
Dr. Chepsey, go ahead.
Yeah, Dr. Castle, it was really fascinating to listen to your experience. Just wanted to know, in your experience, if patients have relapsed after your transplant, what has been your approach, and any thoughts on how to do that?
Yeah, so I mean, we don't have a lot of data there. We have had a number of cases that have relapsed after autologous transplant, and the large majority do not do well. This is the situation in which an allo transplant might make sense, but again, sometimes the patients, are too old to go for that, or they don't have a donor. But in an ideal world, right, you will try to give him another type of regimen. If you use ICE, maybe you can do GMOX and things like that, and maybe add an additional, anti-myeloma regimen that had not been seen previously. Maybe you can add lenalidomide in that setting, or maybe add carfilzomib maybe that setting, and then try to get the patients to an allo stem cell transplant. I mean, there are some of these cells do express CD19. So, I mean, CAR T cells could be a potential option for these patients too. But really, there's no data on it at this time. I wouldn't be surprised if BCMA is highly expressed on these. I think there is some data on BCMA expression in plasmablastic lymphomas too. So belantamab or CAR T cells against BCMA might be another option, down the road. But again, it's just the cases are so few, and then the options are so many that it's going to be very difficult to try to put all this together. But biologically speaking, right, understanding how these cells do have and what do they express might give us options in terms of what to do in the future. But yeah, the only curative option after a failing autologous transplant would be an allo transplant.
Thanks.
Thank you. There's one question whether there is any data on IMiDs, lenalidomide and others in this disease.
Yeah, I mean, it's just in the case report scenario. I think lenalidomide has been used in a number of cases. But not as a single agent. I wouldn't use it as single agents, right? Unless really there's nothing else and you just want to do something for the patient for palliation. Maybe that's not a bad idea. But yeah, I mean, you could make a case, right, and say, well, maybe let's give this patient some CHOP with lenalidomide and see how that works out. That's definitely a reasonable option. But again, there's not a lot of data supporting that approach. But biologically speaking, it does make sense, right? Because it's an anti-myeloma regimen.
There are two questions about diagnosis. One is, do you face difficulty in differentiating plasmacytomas from plasmablastic lymphoma?
The answer is yes. And again, that's where sometimes the clinic helps in that specific scenario. If the lesion is in the mouth, that's plasmablastic lymphoma until proven otherwise. And that's where the location helps. If an HIV positive patient, that's a plasmablastic lymphoma until proven otherwise. If there's EVER positivity, I think that's plasmablastic lymphoma until proven otherwise. If the bone marrow is clean or there's the electrophoresis is negative, right? So I think that also supports a plasmablastic lymphoma over a myeloma or a plasmacytoma scenario. Again, there are some situations in which we do not know, and that happens. But again, using the clinic and the pathology, we might try to make the best out of the whole thing.
Thank you. One question is about whether you always need IHC or you can do a flow and immunophenotyping and diagnose.
I prefer to have a piece of tissue to look at. Fine needle aspiration tissue per se is not great. So whenever we're thinking about lymphoma, a chunk of tissue is better than a little bit of tissue. So I'd rather have a biopsy for formal IHC evaluation. We need to look at the architecture. There are so many other factors that we need to take a look into. So having more material is always a good idea.
The last question is, if the EVER is negative, will you favor plasmacytoma versus a lymphoma?
If the EVER is negative, not necessarily. If the EVER is positive, I think it really leads me very much toward plasmablastic lymphoma. But if it's negative, I don't think it really eliminates plasmablastic lymphoma, specifically because in HIV negative patients, right, the EVER positivity is like 20 to 30%. The majority of patients will be negative for EVER in that specific setting. So I think the problem of differentiating plasmablastic lymphoma versus plasmacytoma is much more difficult in the elder HIV negative patients. That's where it becomes a bit more problematic to be able to figure all that out. And that's where I doing a bone marrow biopsy, doing scanning, kind of a myeloma workup, and if we don't really see any other clinical pathological features suggestive of myeloma, then that might be that give us a better idea that this could be a plasmablastic lymphoma.
Last question does it come up is plasmablastic lymphoma MYD88 positive?
The answer is no, but you always find the exception to the rule. We just published a case in which my two worlds collided, right? Because I do have my practice for Waldenstrom's, which is the biggest, and I have my practice for plasmablastic lymphoma, which is a little separate, and then I have a patient with Waldenstrom's that studied ibrutinib, and then transformed into plasmablastic lymphoma. So and that we just published this case, a few weeks ago. Unfortunately, this is the case in which the company didn't want to pay for bortezomib, so we gave the patient just chemotherapy. And she responded initially for a couple of cycles, and then the disease progressed very much. She was very elderly, very debilitated, so she decided not to pursue any additional treatment, and she ended up passing from the disease. But yeah, so short answer, MYD88 is negative in plasmablastic lymphoma.
Thank you, Dr. George Castillo. That's all what we could discuss. And I must say that this is one of the best lectures we have ever had. A lot of confusion on this disease have been sorted out in this 1 hour.
No, thank you very much for the invite. I mean, it's a great honor for me to be able to transmit some of this knowledge into the practice so far away from the United States in India. So please, if anybody has any questions about anything, you want the slides, anything at all, please reach out to me. I'll be happy to be of help.
Thank you, and bye-bye. Have a wonderful day.
Everybody has a nice rest of the week. Bye.
Now it's my pleasure to introduce the next speaker. And so we have Dr. Kerry Savage. She's medical oncologist, British Columbia Cancer. She's professor of medicine at University of British Columbia, Vancouver, BC, Canada. And we have her lecture on anaplastic large cell lymphoma. Kalpesh, go ahead.
Hi, I'm Carrie Savage from BC Cancer in Vancouver. It's a pleasure to be involved in this meeting today. I'm going to be covering anaplastic large cell lymphoma. Here are my disclosures. By way of introduction, I'm just going to take you through a brief historical perspective of ALCL. It was in 1985 that Stein and Lennart described P1 lymphomas based on characteristic morphology and growth pattern, with P1 later identified as CD30 or the TNF receptor family of the TNF receptor family. Subsequently, the 2,5 translocation resulting in an NPM-ALK fusion gene was discovered, and since then there's been other multiple partners identified, but the end product is an ALK protein with tyrosine kinase activity that can be expressed in a proportion of systemic ALCL. It was in 1999 that we saw the first prognostic study evaluating ALK positive versus ALK negative, showing that the former had a more favorable prognosis. In terms of classification, we saw in the updated Kiel classification that large cell anaplastic lymphoma found a place. And in the real classification, ALCL was described as T and null cell types, the latter referring to the fact that T cell antigens may be absent. In the WHO update in 2001, primary cutaneous ALCL was importantly separated from primary systemic ALCL based on a more indolent behavior and favorable prognosis. In 2008, ALK positive ALCL was defined as a distinct entity, with ALK negative ALCL a provisional entity, as it was defined at that time more by what it wasn't than what it was. In the ensuing years, there was a collective evidence to support that ALK negative ALCL should be a distinct entity. And then we also saw in the last update of the WHO a provisional category of breast implant associated ALCL. So as of today, we have 4 different categories of ALCL. In the interest of time, I'm focusing on systemic ALCL. So shown here is the pathology of ALK positive and ALK negative ALCL. So morphologically, they look the same, and the difference being expression of the ALK protein in ALK positive ALCL. Just as a reminder, not all CD30 positive T-cell lymphomas are ALCL, and CD30 expression can occur in other purple T-cell lymphomas. This is just an example of PTCL-NOS, where the expression is more heterogeneous and spotty than what we see with ALCL, where it's strong and uniform. There are some immunophenotypic difference between ALK positive and ALK negative ALCL. Just by way of example, CD2 and CD3 expression are more common in ALK negative ALCL, whereas cytotoxic markers like TIA1 are more common in ALK positive ALCL. Javid Iqbal and colleagues from the LMPP defined that there is a unique gene signature of ALK negative ALCL, distinguishing it from both ALK positive ALCL, but also PTCL-NOS. As I mentioned, the first study that we saw prognostic difference between ALK positive ALCL over ALK negative ALCL was over 20 years ago. But since then, there's been multiple studies with the same theme of ALK positive ALCL having a more favorable prognosis. What's interesting is the spectrum of prognosis that we see with ALK negative ALCL, with a low of 15% in one study up to 58%. And I think we're gaining information why we see diversity in ALK negative ALCL. ALK negative ALCL is now composed of at least 3 different genetic subtypes, and I've shown here the so-called DUST22 rearranged ALK negative ALCL, which has the characteristic morphology we would expect from ALK negative ALCL, but also occasional donut cells shown in the inset, strong and positive CD30 as we would expect. Cytotoxic markers are typically negative, phospho-STAT3 is negative, and PDL is negative. The first study looking at prognosis in DUST22 rearranged ALK negative ALCL was from Andy Feldman and colleagues, where they evaluated a cohort of systemic ALCL and compared ALK negative genetic subgroups with ALK positive ALCL. And as shown here, the outcome in DUST22 rearranged ALCL was excellent, and it was indistinguishable from ALK positive ALCL. On the other end of the spectrum were a small number of cases with TP63 rearranged ALK negative ALCL that had a dismal prognosis, with 5-year overall survival on 8%. And the large majority fall into this so-called triple negative category, meaning they lack any rearrangement, and with a more intermediate prognosis with 5-year overall survival of 42%. But you can appreciate that if you have a different proportion of these different subtypes, you may see differences in outcome across studies. The first study trying to validate the findings was only 5 cases, but it did show that the outcome was excellent in DUST22 rearranged negative ALCL. But there's been a couple of other studies, including from our own institution, and more recently from the Lugano meeting by Dr. David Sibin and colleagues of 45 cases. That actually represents the largest validation. And interestingly, the outcome was not as good as what we've seen in other analyses. And in the Sibin study, the overall survival was not different than DUST22 not rearranged ALK negative ALCL. So what are some differences if we kind of dissect these studies? There's, again, highlighting that the numbers are all very small, so that makes it a challenge right off the bat. But the age in the earlier studies is younger than what we saw in our own study and David's study, so perhaps that's important. The latter 2 studies were the only ones to really detail those extranodal sites of involvement, and we saw, and Dr. Sibin saw, about 1/3 of cases had bone involvement, and a moderate number of cases had bone marrow involvement. So perhaps these other factors may actually impact prognosis. And I've outlined the comparison of outcome across the bottom there. I think we have definite evidence that DUST22 rearranged ALK negative ALCL is distinct subtype, and it's typically, in my mind, associated with favorable course. But there may be more to it than that, kind of like what we see with ALK positive ALCL. Not all patients do well, and we're going to need larger studies to really understand and see if there's other biology that layered on. But I think the other prognostic factors are still important when we look at the whole picture. FISH studies are now, for these 2 rearrangements, are now being done in a number of laboratories, and including at our own. This was an earlier study just showing the importance of age in comparing ALK positive and ALK negative ALCL, again from David Stibbin and the Gila group. So they looked at all patients that were enrolled on prospective studies, and much like other studies showed the importance of ALK positive phenotype. But this was confined to patients over the age of 40. And if they took the patients under the age of 40, keeping in mind these numbers are small for ALK negative ALCL, there was no difference in outcome. So again, just kind of speaking to looking at the whole picture, it would be interesting to know what proportion of these younger patients may have been DUST22, obviously, but I think this is still important information to layer on the whole picture. The IPI does work in ALK-negative ALCL. So this is from our own study with the International T-cell Lymphoma Project. But just to make the point that patients with multiple IPI factors, so for 3 or more, have a 5-year overall survival that is similar to other PTCLs. And we see a similar picture with ALK-positive ALCL with those with 3 or more factors, a 5-year overall survival of 30%. So we do see high-risk patients even in this setting. So pulling it all together, so this is just for systemic ALCL. We have these 3 categories, and I think just also to highlight, triple negative, I think, is not completely fully defined, and there's likely heterogeneity within that group as well. In our own study, we found a CD3 expression associated with a poor prognosis. I suspect that in the next ensuing years, we'll see further division within that group. I'm going to shift now to therapy considerations in anaplastic large cell lymphoma. So just a couple of points to start us off. Historically, CHOP has been considered standard therapy for all peripheral T-cell lymphomas, including ALCL. CHOP has been increasingly used, as well as consideration of consolidative transplant, at least in ALK-negative ALCL, given the higher relapse rate. And then in recent years, we've seen brentuximab vedotin move to the frontline setting. I'm going to talk about CHOP and use of consolidated transplant first, and then we'll talk about BV in the frontline setting. So where did the data come from using etoposide in the frontline setting? It was actually the study from the German high-grade non-Hodgkin study group, which first reported the outcome of patients who had received etoposide with part of their frontline regimens versus those that hadn't. So they did a retrospective analysis of patients that had been enrolled in prospective high-grade lymphoma studies and confined the analysis to patients with a T-cell phenotype, removing those with are focusing mostly on the nodal subtypes as shown here. So if you take all comers with T-cell lymphoma, a third of which had ALK-positive ALCL, and just ask the question, what is the outcome? What is the event-free survival in patients who receive etoposide with their frontline regimen? There was an improved event-free survival. As a reminder, these studies were done in young, good-risk patients with a normal LDH. If you split out the patients with ALK-positive ALCL, they seem to derive the most benefit from the addition of etoposide, although keeping in mind those numbers are small. And there was just a trend that didn't quite reach statistical significance for the other PTCL subtypes. Some caveats with this analysis. I mentioned the main benefit was seen in ALK-positive ALCL. It was unadjusted for other factors, and there was no overall survival difference. We also looked at this with David Sibin, where we were focused on looking at ALK-positive ALCL adult patients, given that most of the literature is in pediatric and young adult. And this is a pooled analysis of 263 patients. And one of the questions we looked at is what is the outcome in CHOP versus CHOP. Again, numbers are not huge, but we see a similar theme here as what was seen in the German study, and even an overall survival benefit. We have the usual caveats, and across other PTCLs, there's similar themes, and perhaps in the younger patients, there might be improved outcomes. So CHOP is an accepted alternative to CHOP across PTCLs. What about consolidated transplant? This is a topic all in itself, and I have to reduce it to 2 slides. But I just want to highlight I think, a very important prospective phase 2 study by the Nordic group. So as a reminder, this took patients up to the age of 67. It was conducted over 6 years in 24 centers, just to kind of highlight that selection of patients that go into a trial like this. 31 patients that went into this study had ALK-negative ALCL, and ALK-positive ALCL obviously were included, and most would have had a good performance status. At the end of the day, about 70% of patients went on to have consolidated transplant. If we look at the intention to treat population, the 5-year PFS was 44%, so a little better than what we'd expect historically. And by subtyping out by PTCL subtype, this is not statistically significant, but there was a hint that ALK-negative ALCL may do better with the transplant. But again, this is a small number of patients with a good performance status. With the updated analysis that was presented at Lugano, the 10-year overall survival was sitting at about 48%. So moving beyond standard chemo and consolidated transplant, I'm going to touch on a new therapy in ALCL, CHEP-BV. So going back in time, CD30 has always been of interest as a therapeutic target. The nascent monoclonal antibodies were very disappointing in both Hodgkin's and ALCL. So an antibody drug conjugate was developed where MMAE or monomethyl auristatin E is conjugated to anti-CD30. It's taken up into the cell, the dipeptide linker is cleaved, and the MMAE goes into the nucleus, interferes with mitosis. We are learning that the mechanism of action of brentuximab vedotin is actually a little bit more complicated than that, and there are also some effects on the microenvironment, which is important to think about when it's being combined with other agents like checkpoint inhibitors. I've shown here the waterfall plot from the original registration study where the overall response rate was 86% with over half of the patients achieving a complete remission. And in the bottom curve is the updated analysis with a 5-year follow-up with the median PFS sitting just under 2 years. And it was around 14% of patients that went into this study had received BV as a single agent with no subsequent transplant, likely due to age, who remain in complete remission with longer follow-up. So this suggests that in the small percentage of patients, BV is actually curative in the relapse setting, which is quite remarkable. This data led to exploration of BV in combination with CHP with removal of Oncomen or vincristine due to overlapping toxicities in peripheral neuropathy. I'm showing here just the concurrent as opposed to the sequential, which was also explored but not as efficacious. And with the 5-year follow-up in newly diagnosed CD30 positive PTCLs, the majority of which were ALK-negative ALCL, the 5-year PFS was 52%. And interestingly, none of the patients had received autologous stem cell transplant. This led the rationale for the double-blind, double-dummy phase 3 Echelon 2 trial, comparing CHEP-BV to CHOP in CD30 positive purple T-cell lymphomas. Just shown here the brief eligibility. They were treatment naive. CD30 expression was by local laboratory, had to be at least 10% or more. For ALCL, that is a non-issue as CD30 is strongly expressed by diagnosis. And the study targeted 75% of the patients to have systemic ALCL. And that was based on regulatory requirements in Europe and Canada, as this was intended to be a confirmatory trial for the original indication in the relapse setting. I've shown here the histologic subtypes as well. Just as a reminder, for L-positive patients, they had to have 2 or more IPI factors based on the excellent outcome in the 0s and 1s. The primary endpoint was progression-free survival, and events did not include planned consolidated radiotherapy and stem cell transplant. By study design, 70% of the patients at the end of the day had systemic ALCL, so this is the bulk of the patients going into the trial, with numbers between about 25 and 40 in the next 2 common subtypes, NOS and angioimmunoblastic T-cell lymphoma. This is the original public figures from the publication with a median follow-up of 3 years, with statistically significant progression-free as well as overall survival. So the delta for PFS was about 13%, and there was an over doubling of the median PFS. This is the forest plot from that publication, just to highlight the clear results for ALCL, and it just becomes a little bit fuzzier for the other subtypes, but particularly angioimmunoblastic T-cell lymphoma. This data was updated and presented at ASH last year, as well as some of the other meetings this year, with results holding true. And I've just shown here the intention to treat population on the left and systemic ALCL on the right, and comparing those 3 and 5 year estimates for all patients. The 5-year PFS for CHEP-BV was 51.4% versus 43%. Because of those small numbers and more uncertainty on the forest plot, just to highlight, there was some differences in the regulatory approval of CHEP-BV and CD30 positive peripheral T-cell lymphomas, with the FDA being the most broad. In Canada, we somewhat restricted to the 3 main subtypes, and in Europe, it's restricted right down to systemic ALCL, as those were the bulk of the patients that went into the study. This is just relevant for other PTCLs. There is no cutoff for CD30 as there was for the actual clinical trial, and Grastafil is recommended when CHEP-BV is being given. One question we had is whether if you improve the upfront treatment, do you still need that consolidated transplant? And this was presented at ASH a couple of years ago. The short answer was no, we can't use the data from Echelon 2 to say that we can do this, but just to let you know how some limitations of this analysis. So we looked at patients who were in a complete remission after their frontline therapy to remove some of the heterogeneity, and then ask the question, what was the outcome in patients who had had a consolidated transplant versus those that didn't. And as you can see here, the progression-free survivals favored patients who had received a consolidated transplant. There's lots of caveats to an analysis like this, which is post hoc, but we'll have to see larger studies, I think, kind of teasing out which patients don't need to go onto a consolidated stem cell transplant, and clinical factors like the IPI still are important in making these decisions. What do the guidelines recommend? Well, the NCC hadn't quickly updated their guidelines as soon as that data was out, and with CHEP-BV being the preferred regimen. This is also our preferred regimen. We still do consider stem cell transplant in ALK negative ALCL. In other jurisdictions, like in Europe, I know they are using it in ALCL. They just don't have written guidelines yet for me to share with you today. I just want to mention a couple of words on breast implant-associated anaplastic large cell lymphoma. As I mentioned, this is now a provisional entity in the WHO. So if the first case report was actually way back in 1997, and it was in 2011, so 10 years ago, that the FDA issued a warning of a possible association of breast implants and ALCL after 34 cases were reported. And in the last update of the WHO, it was labeled as a provisional entity. 2 years ago, the FDA had a safety meeting, and they were encouraging cases to be reported. And more recently, there were pathology practice guidelines established. This was led by Elaine Jaffe, and I draw your attention to an excellent paper in JCO that really highlights the necessary workup for these cases. Overall risk is actually a little bit hazy as it is underreported, and we see a range across different jurisdictions. But we do know that it seems to be a problem only of textured implants, with finding that allergens biocells seem to be highest risk, and this did lead to a product recall. The median time from implant to EIA ALCL is about 8 years. And for most patients, the outcome is favorable and can be treated with surgery alone. So this is just a picture of what it looks like. So the majority of patients clinically will present with just an effusion or a seroma, with only about 15% having an axillary mass or a breast mass. The pathology is as expected for negative ALCL, and strongly CD30 positive, typically cytotoxic marker positive, variable expression for EMA. More recently, there's been some exploration of the genomic features, and there's a hypoxic gene signature described. There's activation of the JAK-STAT pathway and abundant expression of PDL. DUS22 and P63 rearrangements are negative, and more recently, there's found to be associated with the loss of chromosome 20q. So all of these findings supporting that this is truly a unique biology and separate entity, and it felt to be triggered by the local inflammation from the implant itself. There's an excellent How I Treat article by Dr. Nita Shaw that I would also draw your attention to, that was published in Blood. This is just showing the outcome by treatment, and you can see the overall survival was not impacted, whether patients receive chemo. So most patients can be managed with surgery alone, and chemotherapy reserved for patients with more locally invasive disease or nodal involvement. I'm going to shift to relapsed refractory anaplastic large cell lymphoma. In thinking about management, it's similar to what we would think about in relapsed refractory peripheral T-cell lymphoma, with what treatment goals are in mind. Is transplant on the table, as we know that it's only curative option? Some of these patients may have received transplant up front, so we would only be thinking about, say, an allogeneic transplant if they were an unusual late relapse. Otherwise, if a patient is not transplant eligible, then we really need to be thinking about treatments that balance efficacy as well as toxicity, as opposed to bridging a patient to transplant. Some other considerations for specifically in relapse refractory ALCL. So shown you data that supports that BV is highly active in BV naive relapse refractory ALCL. But what about the efficacy of BV in patients who already received CHEP-BV? So I'll touch on that in a moment. Combination salvage obviously is on the table, as we do for all aggressive lymphomas, and that could be a consideration as a bridge to transplant, not as appealing in the non-transplant or post-transplant population given the excessive toxicity. There are some novel agents approved beyond BV across PTCLs. I'll touch on that. How do we choose them? Is this better than palliative chemo? Circling back to CD30, so brentuximab vedotin is not the only drug that's being developed to target CD30. I'll touch on that as well. And then there's tumor targets beyond CD30. So what lessons have we learned from Echelon 2? Well, with the 5-year follow-up data, we can say that about 40% of patients will still fail CHEP-BV. It's higher in ALK negative than ALK positive. This is in comparison to about 50% post-CHOP. With long-term follow-up, about 20% of patients will have persistent neuropathy. It actually is very similar to what you would see with vincristine. Most is grade 1, but there are around a quarter of those with persistent neuropathy that have grade 2, which can interfere with activity. And then a minority, it was actually only one patient that had grade 3 and no grade 4. From Echelon 2, there was 29 patients in the CHEP-BV arm that received subsequent BV, mostly as a single agent, and there was 54 in the CHOP arm. So I'm going to focus on that for just a minute. This was presented also at ASH last year, asking the question, can you reuse BV in these CHEP-BV patients? And the answer is yes. This is a limited analysis that was unplanned, and the response was by investigator, but we are seeing a response rate in this setting sitting at around 60%, and just similar to whether patients were in the CHEP-BV or CHOP arm. Most of the patients obviously had systemic ALCL, so it's a bit harder to say for the other subtypes, but there does seem to be a signal there. So at the end of the day, if a patient does not have any more than grade 1 peripheral neuropathy, then BV retreatment is reasonable and most appealing, I think, as a bridge to transplant. So you're not planning on giving multiple cycles where you might get into trouble with peripheral neuropathy. What about post-BV? What is the outcome? Well, not too surprisingly, it's poor. We looked at this with Dai Kaihara, and this curve is focusing on those patients who had BV and what is their subsequent overall survival, and it was sitting at about 27%, with the median of only 3 months. With most of the long-term survivors are those, not surprisingly, who have undergone subsequent stem cell transplant. So this is clearly an area of unmet need. Beyond BV, there are other FDA-approved drugs in relapse refractory PTCLs, and that would include ALCL. I'm trying to focus just on systemic ALCL, and not all of the studies have reported details for ALK negative and ALK positive. But the response rate is modest at best, comparing pralatrexate and the HDAC inhibitors, and really, in my mind, no biological clues to guide me from one to the other. just also to highlight one other wrinkle, we heard in August that BMS has withdrawn the indication romidapsine for relapse refractory PTCL based on the negative study of romidapsine versus Rochop. So it's unclear how that is going to impact access to this drug. It is also still available in cutaneous ALCL in the US. The standout on this table is clearly crizotinib, so that's an ALK inhibitor that can be used in ALK-positive ALCL. So this was actually just FDA approved in January of this year, but only patients 21 or younger. And I want to spend a couple minutes on this because I think it's important for us to remember in ALK-positive ALCL patients that are doing badly. So most of the patients, the median age of ALK-positive ALCL is around 30, so we don't have as much information in general in older patients, including what is the efficacy of this drug. But there was a small phase 2 study that was published last year of 12 patients, where patients had at least one prior line. The median age was 31. Only 25% of patients had received BV previously, which I found a bit surprising. And only one patient went on to have a subsequent transplant. Regardless, the response rate was high, 83%, with over half having complete remission and 2-year PFS of 65%. There are some toxicities associated with this drug, and about 3/4 have a grade 3, grade 4 toxicity, with the 2 to flag are diarrhea and visual changes. There are new generation ALK inhibitors that, and this is an example of one of them called alectinib. So it obviously used more in non-small cell lung cancer, and there was a phase 3 study in lung cancer showing better efficacy. It also crosses the blood-brain barrier. So in that study, there's lower CNS events, but that could be important, as we know that rare patients with ALK-positive ALCL can relapse in the CNS. And it also had lower toxicity across the board, and but importantly, no visual disturbances. What about the data in ALK-positive ALCL? Well, this is the only one I could find of 10 patients. The median age was 19 and a half. They did take patients up to the age of 70. Half had prior BV, and the overall response rate was similar we see previously, with a CR rate of 60% and a 1-year PFS sitting at around 58% with 2 patients who had undergone subsequent stem cell transplant. So if we can get a hold of it, I think this drug has promise in ALK-positive ALCL. What about palliative chemotherapy? I just want to flag one drug that's from old literature, vinblastine. The pediatric landscape has a lot more experience with relapse refractory ALK-positive ALCL than we do, so we can actually learn a lot from them. But this was a study evaluating vinblastine in patients who had failed transplant, and they found that about 1/3 of patients were salvaged with prolonged weekly vinblastine therapy. So for me, this is something I keep in mind if in patients who don't have any other options. What are some other non-approved drugs? We have to have clinical trials at the top of the list in this setting, but just some other drugs for us to consider: gemcitabine, bendamustine, lenalidomide, and duvelisib. Most promising, I think, is the explosion of combination studies across all relapse refractory PTCLs, and most of these studies would also include ALCL. Can we learn anything from genomics to feed therapy decisions? I think the one pathway to flag is JAK-STAT pathway, which might be active in a proportion of ALCL. So there are some studies out there evaluating JAK inhibitors, and I'm just flagging one from Lugano this year called the JAKPOT-8 study in relapse refractory PTCL, including ALCL. The overall response rate of this agent in 42 patients was 48%, with generally acceptable side effect profile. Don't have a lot of information in ALCL. They only had 3 patients with ALK-negative ALCL and none with ALK-positive, and 2 out of 3 had a response. Ruxolitinib has also been explored in a phase 2 study. So this is from Alex Moskowitz from the Memorial Sloan Kettering, where there was 3 cohorts, 2 of which demonstrated some biologic rationale either through mutation or functional evidence of JAK-STAT mutation. And the overall response rate sitting at about 30%. And again, small numbers for ALCL with similar overall response rate. So we'll keep an eye out for the JAK inhibitor studies for ALCL, and probably would be in, with combinations if we see this moving forward. I want to spend the last few minutes just talking about immunotherapy and relapsed refractory ALCL, which is definitely a work in progress, but just to give you a flavor of what's happening out there. In the interest of time, I'm going to focus on CAR T-cell therapy, mostly in CD30, as well as bispecific antibody therapy. PD-1 inhibitors, that's a whole other discussion, but not a lot of data in ALCL. CD47 is being targeted across PTCLs with particular promise in CTCL. So starting with CAR T-cell therapy in purple T-cell lymphomas. So not surprisingly, CAR T-cell therapy is lagged behind PTCLs and in B-cell lymphomas, and not by virtue of not having targets, but there are three fundamental problems when thinking about design of CAR T-cell and T-cell lymphomas. One is T-cell aplasia. So if a specific T-cell antigen is targeted, it can lead to profound immunodeficiency. Fratricide, where we can see CAR-on-CAR killing. And then there's the potential for product contamination with malignant T-cells. So CD30 is kind of the farthest along in studies, and I'll just take you through a couple of them, and I'm going to try to highlight the data specifically for ALCL. So this was the earliest study we saw published now about 4 years ago of a CAR product against CD30. There was only 9 patients, 7 of which had Hodgkin's, and only 2 had ALCL, one of which had L-positive ALCL, and the patient entered a complete remission for 9 months. This same group established that lymphodepleting chemotherapy was critical for CAR T-cell expansion. So typically fludarabine and less commonly bendamustine-based lymphodepleting chemotherapy is integrated into studies now moving forward. This is a summary of the CD30 CAR T-cell therapies to date. Again, I've highlighted the ALCL patients. So you can just see here that the numbers are all small, and there are some differences in which co-stimulatory domain has been used. I want to focus a little bit on that one at the bottom by Wang and colleagues that was published last year. So there were this product differs from the others in that it has a combination of CD28 and 4-1BB. And the investigators credit that to this being a more effective CAR. And this is although obviously the numbers are small, but this is the best data we've seen so far for ALCL. So these are three patients, 2 of which have entered a complete remission. And at the time of this study being published, they were in ongoing complete remission, 1.5 to 2 years following the CAR T-cell therapy. The final patient had stable disease and did have a significant CRS and did require ionotropes and ultimately died of infection. Beyond CD30, there are other targets on malignant T cells, and this would also be true for ALCL. CD5 is a negative regulatory of TCR. There's an ongoing Magenta study. No ALCL patients that we've seen so far reported, but 4 out of 9 responses at the last public presentation at ASH. CD7 has a role in T cell activation, but it does have the problem of fratricide, and there have been novel approaches to avoid or limit fratricide, including a so-called off-the-shelf CAR T called UCAR7 that used CRISPR and Cas9 editing so that it lacked CD7 and TCR alpha. The other one just to keep an eye out for is a CAR T against TCR, which capitalizes on the fact that TCR beta will use either TCR-BC1 or TRBC2 so that a treatment can be developed against one or the other, with the alternate one being spared. So it's agnostic to PTCL type. It eliminates fratricide given this selectivity for one or two and preserves immunity. And there is an ongoing trial evaluating CAR T against TRBC1 in relapsed refractory PTCL. The other one just to keep an eye out for is allogeneic anti-CD70 CAR T cell. So these are off the shelf, again using CRISPR and Cas9 editing, this time to eliminate TCR alpha and B2M. And there's an ongoing phase 1 study in refractory B and T cell lymphomas. And then aside from T cells, using NK cells as the product is appealing, as it often lacks the targeted antigens and can also be off the shelf. Shifting to bispecific antibodies, which have clearly been a home run in B-cell lymphomas, particularly follicular lymphoma. So this was a bispecific product that was an innate B-cell engager targeting CD16A and CD30 that was evaluated in Hodgkin's lymphoma. So it was very lackluster with an overall response rate of only 11.5%. But there was a study published last year combining this agent with pembrolizumab with encouraging responses with a CR rate of 37%, which is higher than what you would expect from a PD-1 inhibitor alone. So we may see more data with this agent in combination with other drugs coming in PTCL. What about AFM 13 as a single agent? Well, this was presented at ASH last year with a smattering of relapsed refractory ALCL. And interestingly, the response rate is higher than what we saw in Hodgkin's with an overall response rate of 40%. 4 patients that had prior BV. We have not seen what the durability is, but it's possible that this agent does have higher efficacy in PTCLs than what we were seeing in Hodgkin's lymphoma. So just to sum up, as I've mentioned, we should now think about ALK-negative ALCL as 3 different genetic subtypes, and if possible, this study should be performed in newly diagnosed patients. CHEP-BV is now a new treatment paradigm for systemic ALCL. There's still some outstanding questions. In my mind, I still don't know who may need a stem cell transplant now, negative ALCL, but I'm looking at the whole picture, all the information, making those decisions. We also don't know about the risk of CNS relapse, but I suspect it probably hasn't changed, knowing that BV does not penetrate the blood-brain barrier. And we may see that more as more patients are cured. There could be a preponderance of CNS relapse. Post-CHEP-BV, we can think about BV again if there is minimal peripheral neuropathy, and especially the bridge to transplant. Beyond BV, I still think a clinical trial would be preferred. In the CAR T cell land, we are seeing some encouraging responses early, but the data is still early days and durability is unknown. And we'll have to keep our eyes open for the other ongoing studies across all relapsed refractory peripheral T-cell lymphomas in this space. Thank you for your attention.
Thank you so much, Dr. Carrie Savage, for that lovely talk. Enjoyed listening to it. And we have some questions here from the Indian faculty for you. Dr. Kripa.
Thank you, ma'am, for the excellent lecture. I have one question for you, 2 questions for you. One is, we do use GMOL regimen rather CHOEP regimen for ALCL patients. So do you use any intensive protocol in any specific setting, clinical setting, ma'am? Like whenever in extensive stage 4 disease is that we used to prefer GMOL rather CHOEP because of the poor outcome in our patients. So do you use any intensive protocol similarly for your patients in any setting?
Sorry, if I understood correctly, you use a regimen called GMO?
Yes, ma'am.
Do you mean GEMOX with oxalipatin? Is that what you're... I'm not familiar with GMO.
RGMOL without any rituximab. RGMOL regimen without rituximab. The methotrexate based regimen.
What are the agents in the regimen you use?
So without etoposide, we'll have cyclophosphamide as well as high dose methotrexate. Everything will be there. Etoposide similarly, but the different infusion will be there. Methotrexate also will be the addition in that. So
okay, interesting. I haven't heard of that regimen before, so I don't know if that's extrapolated from pediatric, but before we had CHEP-BV, we would have been using CHOP and on occasion CHOA. But are you talking about for a high risk patient, whether CHEP-BV is enough? Is that your question?
Yes, ma'am.
Yeah.
High extensive disease patients.
Yeah, and it's a good question. So just to loop back to Echelon 2, so it included all patients with ALK negative ALCL, and ALK positive ALCL patients had to have a score of 2 or more. Because it's a clinical trial, we are not going to have those highest risk patients because they probably wouldn't have been eligible for a clinical trial. So I think it'll be interesting in the upcoming years to see real world data of CHEP-BV across all ALCLs, and probably that would be from the US as soon as it was approved at the FDA. That was November 2018. It was automatically being used. But I don't venture beyond what, beyond CHEP-BV at this point, integrating other agents. I think if somebody has a high CNS risk, again, that's a whole kettle of fish as well. It's complicated even in DLBC. We don't have data. I think if somebody had really high LDH and perhaps kidney involvement, I might extrapolate and use it as a one-off. Try to integrate it likely at the end, because I don't know how methotrexate would blend with CHEP-BV. And then we are still considering consolidative transplant, mostly really just an ALK negative ALCL. It's not my practice to use an ALK positive ALCL in more high risk patients as well. I hope that answers your question.
Yes, I understand.
Okay.
And one more question, where do you place the ALK inhibitors, the crizotinib, alectinib, what you discussed before? Where do you place in adult patients? Because it's not FDA approved in adult patients, but there is some data in relapsed refractory settings where there's a good response.
Yeah, no, exactly. And the approval, I believe only the US has approval. So that was just in January of this year, and it's up to age 21. So in Canada, it's not officially approved, even in the pediatric group. At our own center, we do have compassionate access program where we can apply outside of our funded drugs. So where would I use it? If I had a patient with ALK positive ALCL with relapse disease, and if they're BV refractory, or if they had CNS involvement, because the second generation agents like alectinib can cross the blood-brain barrier, that is a scenario where I would try to access it. And I've done that on one occasion with a young man who's 19 years old who had that kind of scenario. But I think other than that, I wouldn't be using it obviously up front, or I wouldn't use it in place of BV, because I have the long-term data with BV, and there is, I would say, more toxicity with the ALK inhibitors from what I can see.
Thank you, ma'am. Thank you so much.
Dr. Smita.
Yes, thank you, sir. And thank you, Dr. Keri, for such an educative talk. I have two queries. One is the follow-up from Dr. Kripa's question is for an adolescent patient about 20 years of age, would you treat him with a pediatric inspired protocol? Like in the pediatric, we use those multi-drug chemotherapy with high-dose methotrexate-based regimes, or on the adult protocol?
For a 20-year-old, we
Yes.
start to see patients at BC Cancer at 17, so they start to shift over. So we would be treating someone like that with an adult protocol.
Okay, and where do you place any data on upfront use of vinblastine? As we know, it has activity in the relapsed refractory setting. So when we don't have access to BV or brentuximab, whether bringing vinblastine in the upfront setting would have some benefit?
Oh, that's a really good question. I mean, I don't think that has been studied. So again, I'm using regimens that have been studied. So I wouldn't swap out vincristine for vinblastine in the upfront setting. But I haven't used it before, to be honest, but I like to kind of look at the pediatric literature for ALK positive, because they have a lot more data than we do. And I certainly would consider it in patients so I don't have other options, but I wouldn't move it to frontline.
Okay,
Thank
thank
you,
you.
Dr. Chepsey.
Thank you, Dr. Kerry. That was really informative.
Thank
My
you.
question relates to your experience with allogenic transplants in ALCL, and is there any preferred conditioning that you would advise?
Oh, that's a really good question. And I will confess, I am not a transplanter. I'm a medical oncologist. Our group, I believe, either uses Cy-TBI and beam-based regimens, unless there's CNS disease, in which case they would use a thiotepa-based regimen.
Yeah, thank you.
Chirag.
Yes, Dr. Carey, you mentioned about the vinblastine weekly regimen in palliative setting. That is limited to the ALCL only or for all PTCL?
That study that I showed was a pediatric study in relapse refractory ALK positive ALCL. So it was really specific for that. I actually haven't seen data in ALK negative ALCL or other PTCL. So I would think of that really data specifically for ALK positive ALCL.
Thank you. Dr. Chepsey, you have another question? Okay, we'll take a question from the audience. Is brentuximab used in relapse setting? And if yes, any particular protocol? Do we give 16 cycles like in Hodgkin?
If it's reused, okay, so we can answer that in two ways. So we're going to have patients who are brentuximab naive and others that are brentuximab exposed if you were able to access BV in the frontline setting. So in the original registration study that was published by Barbara Pro, the dose was 1.8 mg per kg, and it was given for 16 cycles. To be honest, that number was kind of pulled out of the air. There wasn't really any data to support that, but that is what has been sort of carried forward. The average number of cycles is usually around 9 or 10, and so a lot of patients drop off early due to peripheral neuropathy. So if I'm using it, I'm watching for peripheral neuropathy. If they're in a CR, I'm certainly not pushing it. And I don't want somebody to end up with long-term problems. There's less wiggle room if somebody's received CHEP BV up front. So they're going to have received 6 cycles. So that's already a chunk of what your, I would say, BV bank has already eaten up. And I kind of see that role, if you're using it again, is trying to get them to a transplant if you haven't transplanted the patients especially. And if you're getting them to a transplant, you're not giving multiple cycles. You're trying to get them into a remission and then move to the transplant. So it's going to be similar to what you would do with any salvage regimen. So I would say 3 to 4 cycles, get a good PR, and then into a transplant. If you're giving it in the situation where you're not transplanting them and they've received BV before, I think there's going to be limitations, and you're not likely to be able to give 16 cycles if you've already given 6 up front. So I think you just have to take each patient individually and watch them carefully for that side effect.
Thank you. Another question is, would you advocate upfront auto transplant for triple negative ALCL who had BV CHOP based on the data presented in ASH 2019?
Would I transplant somebody in first remission who's in a, is that what the question was? Yeah, it's still a bit of a question mark what the role is. So we presented that data at ASH 2 years ago, where we wanted to know whether you need a consolidated transplant if you are if the patient's in a complete remission following their frontline therapy. So that was a very ad hoc analysis, not planned, but it kind of suggested that there was still an elevated risk of relapse in those that weren't transplanted. But my own sort of practice is as I mentioned, I kind of look at the whole picture, and it depends to me on their risk going in. So if they're a high IPI, I would still be considering transplant if they're in a good remission. I don't actually necessarily go for full CR, but they have to have an excellent response if we're going to be going down that path. On the other hand, I actually had a couple of patients that went on Echelon 2. And of course, it was a blinded study, so I didn't know what arm they were on, but they were extensive stage 2s. One had an IPI, I think it was a 2, and the other one was just on the kind of border of age. I didn't transplant either of them, and they both are cured. So I don't think that everybody needs one either. The DUS22 cases, I think those are kind of also a different subtype that generally has a more favorable prognosis. So if I have a typical DUS22 with who's very well low risk, I'm not going to be planning on transplanting those. But on the other hand, I wouldn't necessarily ignore a bunch of high risk features, because I think we still don't have the full picture for that rare entity. And as I mentioned in my talk, our study and the one from the French group found that the outcome is not as good as everybody is reporting. So I think there are some high risk patients. So if patient with bone marrow, high LDH, but they're DUS22, I'm not going to ignore the clinical information. So that's somebody I would consider for a transplant as well up front.
Right. One question is there any data on maintenance therapy after transplant?
Yeah, that's a really good question. So we have obviously data in Hodgkin's lymphoma with a similar paradigm, being CD30 positive, showing an improved PFS. We have no similar data in CD30 positive PTCLs, including ALCL. There's certainly a rationale there, but it's not data supported, and obviously something that I wouldn't be able to access. I will mention there is a study that just to watch for, that we'll probably hear more about this year, that was developed by Alex Herrera out of the City of Hope, combining CHOP, so CHOP with etoposide, with brentuximab vedotin across CD30 positive PTCLs. In that study, he allowed consolidated transplant. It was up to the investigator, much like in Echelon 2, and also integrated maintenance BV, whether patients had a transplant or not. This is a single arm study, so it's going to be hard to sort of tease it all out, but that will be some data looking at the role of BV maintenance in CD30 positive PTCLs. And the reason for doing that study was that a lot of people do use CHOP in PTCLs and not CHOP. And so, and of course, Echelon 2 was not CHOP. So it was looking at efficacy and safety of that regimen. And I think that'll be particularly interesting, I think, in this other CD30 positive PTCLs, because that additional intensity with the etoposide.
Thank you. That was the last question from the audience. Faculty here has any question?
Yeah, Dr. Kerry, just one more question. Your experience and your approach in case you see hemophagocytosis in patients that you treat with PTCL or ALCL? Any
my experience. Pardon me?
Yeah, any change in your regime?
If it's hemophagocytosis?
Yes.
Yeah, I haven't seen it in combination with ALCL, but you're right, it can occur across any PTCL, especially EBV-driven and NK cell lymphomas. We work in concert with the hematologists, and patients like that are getting high-dose steroids and potentially etoposide as we're getting things organized. And then I would be tempted to add in etoposide to my regimen just because of the data with using etoposide in hemophagocytic syndrome. But the bottom line is treating the underlying lymphoma because it's driving the hemophagocytic syndrome. So you just want to optimally treat that.
Thank you.
Okay.
Thank you, Dr. Suresh. That was the last question from the faculty. Before I hand over to Dr. Manoj for official vote of thanks, I thank you very much on my behalf, on behalf of Mumbai Hematology Group, for accepting this invitation, sparing your time and educating us about this disease. And we really benefited today. Now over to Dr. Manoj.
Thank you so much.
Thank you, Dr. Carey, for such insightful and enriching lecture and a wonderful Q&A session. I think tomorrow there are a lot of clinical pearls which clinicians are going to take from your talk tomorrow morning. Thank you, Professor Dr. M.B. Agarwal, sir, for a marathon 5th day, 2 more days to go. And it is apt and rapt, I must say. Wonderful interactions, and we are getting just a lot of accolades. Thank you so much, sir. Thank you to our chief guest, Dr. Prashant Ganeshan, and 2 experts who also enlightened us today, Dr. Dan and Dr. George. They were wonderful too. And all the expert panelists from today, Dr. Chirag Shah, Dr. Asif Iqbal, Dr. Lalit Mohan Sharma, Dr. Varun Bafna, Dr. Sanjeev, Dr. Riaz Ahmed, Dr. Sanket Shah, Dr. Kripa Bajaj, Dr. Chepsi, and Dr. Smita Dyal. All of you made it really, really lively. And sir, once again, there are 13 countries who have participated in big number. India, of course, Malaysia, Sri Lanka, Myanmar, Pakistan, Indonesia, Belgium, Iraq, UK, USA, Bahrain, and Jakarta. Thank you all the delegates who have logged in such a large number. Please remember the day timing tomorrow, 5:45 once again. Thank you very much and good night.
And bye to everybody.